Good morning and welcome to the 17th meeting in 2013 of the Health and Sport Committee. And as usual at this point, can I remind those present to switch off mobile phones and Blackberries as they often interfere with the sound system. People at the table and indeed anyone in the public gallery may notice that some members are using iPads. This is instead of the hard copies of their committee papers. The first item on the agenda is a decision on whether to take item 6 in private. Item 6 is a work programme discussion, which we normally take in private. Can I have the committee's agreement that we take item 6 in private? Agreed. Thank you. We now move on to agenda item number 2, NHS waiting lists. And can I welcome the Cabinet Secretary for Health and Wellbeing, Alex Neil. Welcome, Cabinet Secretary.
Thank you.
Derek Feely, Director General Health and Social Care and Chief Executive of NHS Scotland. And John Conahan, Director of Health and Workforce Performance and Support, Scottish Government. Welcome to you all. Cabinet Secretary, I believe that you wish to make an opening statement.
Just a brief one, if I may, Convener. Thank you very much indeed. And I'd like to take the opportunity just to comment on the recent Public Audit Committee report on the management of patients on NHS waiting lists. Firstly, I welcome the conclusions and accept the committee's recommendations, and I can assure you that we are already acting on them and will follow through. Secondly, I would like to put on the record that deliberate manipulation of waiting, such as was uncovered in Lothian, is completely unacceptable. We have now had the most extensive scrutiny from internal auditors and Audit Scotland, as well as the committee, who have looked at hundreds of thousands of records and interviewed hundreds of staff. It is important to note that evidence of further deliberate manipulation has not been found. Thirdly, on the issue of social unavailability, which is now, of course, historic because we've replaced it with patient unavailability, I should stress that this was originally designed as part of the New Ways approach to try to be fairer to patients, which Audit Scotland recognised in its 2010 report. It was intended to offer convenience and choice to patients without them having to leave the waiting list if the appointment offered to them was unsuitable. We have obviously replaced it with patient unavailability rules, and these are much tighter and have to be agreed by the patient in terms of their unavailability in writing. Fourthly, I would like to assure the committee that this government will ensure that all the recommendations in the Public Audit Committee, Audit Scotland and internal audits reports will all be implemented as quickly as possible. The vast majority of the recommendations have already been completed and the remaining ones are being actioned and should be implemented by late autumn at the latest. Indeed, rather than merely reacting to audit actions, we've also begun an assessment of the overall control framework for waiting times to ensure we have robust controls at every stage. And by December this year, we will have the reports and follow-up audits by internal auditors and Audit Scotland. Finally, due to the 155,000 hard-working NHS staff, waiting times are now at their lowest ever. We now have 53,000 people on the waiting list, a record low for the National Health Service in Scotland, and that is obviously of enormous benefit. And in comparison with other countries, Scotland leads the way. I hope the committee will recognise this, but also take comfort from my commitment to improve both information systems and transparency, as well as performance. Thank you.
Thank you, Cabinet Secretary. Have a question from the committee. Bob Doris.
Thank you, Convener. Good morning. I should really declare an interest that this is a little bit Groundhog Day for myself. I sat through the Public Audit Committee inquiry into this, so unsurprisingly I may refer to one or two of the recommendations from the Public Audit Committee. The Public Audit Committee heard, of course, that there were no deliberate manipulation of waiting times in health boards out with Lothian. Heard that ISD Scotland provided reassurances that 94.3% of patients were getting seen in under 18 weeks and that there were no hidden waiting lists. However, we did also have a number of issues about the checks and balances within the system to make sure it was running smoothly. Greater Glasgow and Clyde now have decided that they will have monthly monitoring of waiting lists there, where they will take a sample amount and they will go back through the records and they will make sure that not only were any patient advised unavailability recorded correctly, but that the system is robust, and that will be done on a monthly basis. That's one of the recommendations that the Public Audit Committee makes for every health board in Scotland. What reassurances can the Scottish Government give that it's going to work in partnership with each and every health board to make sure it's not just Glasgow that are reinforcing the checks and balances within the system, but it's every health board in Scotland?
Well, rather than just give a reassurance, I'll give you a commitment that we are insisting that all 14 territorial health boards and the Golden Jubilee do exactly that, and we're doing it at national level as well. There is now a monthly meeting involving ISD, my own officials and others to in a very detailed way monitor progress and the implementation of the new systems and the new setup that I've already described briefly in overview terms, but also to examine any potential issues that need to be addressed in how statistics are interpreted, how rules are being implemented, etc. So at both national level and at board level, there is now on a monthly basis a very, very detailed scrutiny of the figures to make sure that they are robust and to make sure that we are providing the relevant information, but also information that can be believed by both boards and by the department at a national level.
So, Cabinet Secretary, would you expect then if on the, let's use this month as an example, if a health board this month was to identify any internal issue with the process, but that to be fed directly to yourself the following month at the national meeting?
Well, it'll probably even be fed quicker than that, because if there is an issue, the likelihood is that the chief executive of the board or one of his or her officials would notify my own officials and we would tackle it right away. So rather than wait from month to month, we are tackling this if issues do arise on a much more spontaneous basis, so that action is taken, and if there are any potential problems, they're identified very quickly and they're highlighted, because if there's a problem arising in one board area and it could be of a generic nature covering other board areas, obviously we want to know about that quickly and we want to deal with it. Now, so far, we've actually had one board highlight a couple of issues which turned out not to be big issues at all, and there were perfectly good and rational explanations for the issues that they had raised with us. So we are in dialogue constantly with the boards. I'm in dialogue with the chairs. Derek Feely's in constant dialogue with the chief executives, and John in constant dialogue with his counterparts in the boards as well, and at every level. We are making sure that these statistics are robust in every possible way.
Thank you. So that would appear to be that the checks and balances, where any issues to arise, they'll be tackled in real time rather than waiting from month to month. Can I ask a little bit more about the role of ISD? ISD told the Public Audit Committee that they saw nothing particularly unusual in the increase of the use of unavailability codes, given the move from the previous executives' hidden waiting lists to bringing all of those waiting onto a mainstream waiting list system and other factors. One of the reassurances I got was that ISD do collect total waiting time for patients, irrespective of any patient-advised availability or whatever, and that was where the figure 94.3% came from. However, do you think any lessons could be learned in terms of how the relationship between ISD and the vast quantity of figures they collect and Scottish Government that could perhaps in future provide another check and balance in the system, or an early warning system where there's patterns that may look irregular? Precisely in relation to these patterns, what would the role of ISD? Would it be one of collecting the data, or would it be one of analysing the data and making representations to government?
Well, ISD obviously are the agency that do collect the data, but also they're taking a much more proactive role with us in monthly monitoring of the data and making sure the interpretation of the data is carried out both at a national and at a board level, so that if there are any trends, and we shouldn't get as far as there being trends, because any potential problem should be nipped in the bud before it becomes a trend, but if there were any question marks over particular aspects of the data, if ISD didn't raise it, we would raise it with ISD, and the purpose of the monthly monitoring meeting is to make sure that any issues are identified at national level as well as at board level. So really we are doing two things. Number one, we are monitoring the boards, both in terms of the data, but also in terms of implementation of robust systems to make sure the data is reliable based on the recommendations of the Auditor General, plus the recommendations from the committee, the Public Audit Committee. But also we are looking ourselves at the data at both local and national level to make sure that we are satisfied, along with ISD, that the data is robust, but also obviously the whole purpose of the data is that it's a management tool. So if there are problems with the waiting times, and we do know there are some boards that have got problems and not yet achieving the target, or have more breaches than others, then clearly we are identifying those situations and then dealing with them in conjunction with the relevant board.
One final question, I'll perhaps come back in later, Cabinet Secretary, but you've alluded to what my next question was going to be. I would have thought one of the natures of waiting time targets is where they're not met or there is slippage, is whilst it's never a good thing, one of the useful aspects of it is it identifies pressures in the system. The Public Audit Committee heard that one of the reasons for the increase in unavailability codes in Glasgow was increased pressures in the system, which they then put investment into. So could you say a little bit about how you would expect health boards to use the information held in relation to waiting times to make sure they have appropriate resource allocation to meet targets where there's slippage? But can I ask a second question, because I'm not going to come back in after this one, Cabinet Secretary, and again in Greater Glasgow and Clyde, this is of a constituency interest to myself, obviously. One of the things Greater Glasgow and Clyde did was technically they didn't apply the rules in terms of social unavailability or the like, because they offered 3 attempts where a patient could deem themselves to be socially unavailable, going on holiday or whatever the reason may be, before they referred patients back to their GP. That was technically out with the 2 that they're allowed under the national waiting times policies. Can you just confirm also that that would be it would be fine in terms of yourself, because the Public Audit Committee had a discussion around whether by going beyond the minimum requirements, whether they were actually implementing the policy as required. Could you confirm that that would be allowed? But more importantly, if they can do that in Greater Glasgow and Clyde, if they can offer 3 attempts to find a suitable appointment for surgery or the like, couldn't they do that elsewhere in the country?
Well, I'll answer both of those questions. I'll also give Derek and John the opportunity to supplement my answer, because they may want to bring in additional points that I may not make. But first of all, in terms of pressures, I think it's very important to understand that we do not just look at waiting times. We have a whole suite of data. In fact, we have data coming out of ears in the National Health Service in Scotland. And I look particularly at a monthly report which is prepared specifically for myself and the management board that I now share in the monthly meetings of the chairs of the boards that I chair. So we are looking at a whole range of performance issues. We're looking at delayed discharges, we're looking at staff numbers, staff mix, we're looking at investment, capital projects, we're looking at obviously waiting times in terms of the A&E target, waiting times in terms of the guarantee, waiting times in terms of the 18-week target, waiting times in terms of very specific issues, for example, the 31 and 32-day targets in relation to cancer, for example. So we look at a wide range of statistical data to identify where there are pressures in the system, and then along with the relevant board where we've identified pressures or the board has identified to us that they have pressures, we then work with the board to address those. And I can give you many examples of where that is going on at the present time. So that I don't think you can look at waiting times or any one statistic in total isolation. We're looking at an entire national health system. And I think sometimes people don't realise just the level of demand the National Health Service in Scotland is dealing with. I mean, just some of the statistics are very interesting. 1.5 million people now present to accident and emergency every year in Scotland. We have 24 accident and emergency units, and they deal with 1.5 million presentations. Half the population of Scotland, half of the entire population of Scotland at any one time is under the care of the National Health Service. Now, it might just be for a repeat prescription, or it might be for a terminal illness, but half the population at any one time are under the care in one way or another of the National Health Service. 1/3 of the entire population have more than one thing wrong with them at any one time. So these statistics, I think, 6 million times a year there is a consultation with a doctor in the National Health Service in Scotland. 6 million times a year. And I think the scale of the operation has to be understood. And an operation of that scale, very clearly, you have to look at a whole range of data on an ongoing basis to identify where the problems are likely to be, where there is failure in the system, where there's success in the system. I mean, a very good example of how we're improving things technologically is the launch of the new digital tracking system being piloted in the borders, which will be rolled out to all the health board areas. And that in itself, that's a very, very useful management tool, not just at the ward level, but in terms of the information it summarises at the hospital level and eventually at the national level. So this time next year, we'll have access to much more real-time information. We'll be able to actually identify almost bed by bed, you know, what's happening. So these tools are extremely important, and in a fast-moving situation, which many wards are fast-moving, patients in, patients out, and all the rest of it, it's very important to have those tools available, which, you know, we've got an unprecedented level of statistical collection and analysis and tools like the one in Borders I've just described to make sure we've got as much real-time information as we can possibly collect. So we can, I think, very quickly now identify the pressures and then deal with them. Now, sometimes the solution isn't ready-made in a day. Sometimes the solution takes a bit longer. You know, if you get, a very good example is we're dealing with the pressures in accident and emergency. That's not confined, because of that's not confined to the accident and emergency department. It's about the flow of patients through the hospital. So that if we increase, as we are doing, the discharge percentage of patients in the morning, to make beds available, it relieves pressure on those patients coming from A&E waiting for a bed in a ward. So you have to look at the entire flow right through the hospital. You can't just look at one department, you can't look at one statistic, you have to look at the whole thing. Second question you raised was in relation to Glasgow as an example, which was exceeding the targets that we'd set in terms of offering 3 instead of just 2 alternatives. It's up to each board really to make a decision about whether they go above and beyond the targets that we meet. Obviously, in general, I would encourage them to do so as long as it's not at the price of achieving some of the other more significant targets. It's very important we get consistency in terms of the minimum standards across and minimum targets to be achieved right across the health service. But if a board believes it can excel above and beyond the targets that have been set, then of course you would encourage them to do so as long as it's not at the price of failure elsewhere in the system. And that would be my approach to any board. I would encourage them to try to excel above and beyond targets, but not at the price of creating failure elsewhere in the system. And I don't know if Derek and John would like to add to that.
Only one piece, as the Cabinet Secretary says, and Mr Doss recognised that a reasonable offer in terms of our waiting time guidance is 2 or more appointments within a minimum of 7 days' notice from the date of the offer of the appointment. It is sometimes easier for some boards to go beyond that than it is for others. So if you think about Glasgow, for example, they have the waiting times unit, they have the Golden Jubilee more or less on their doorstep, which increases their reach for their patients. More of a challenge for Grampian or Highland to take use make use of that kind of facility. So, yeah, as the Cabinet Secretary says, we would encourage every board to do as much as they can and to go beyond the guidance if they can. But it's sometimes easier for some than for others.
And if I could add something which is, I suppose, along the same lines, I think the Cabinet Secretary has clearly laid out there that boards are paying a lot of attention to requirements for capacity and demand, matching the available capacity and expanding that where necessary to cope with demand. But we also need to take a look at how the NHS is achieving those targets, and the NHS has a significant investment in redesign and transformation across the entire patient pathway, coping in the past 10 years with a significant increase in hips, knees and cataracts, almost twice as many in 2011-12 as in the year 2000. For example, cataracts, 19,000 10 years ago, and now up to 32,000. Hip replacements, 4,000, now up to 7,500. And it could not have done that without redesigning patient pathways and without investing in that element. So significant extra output and also the lowest number of people on the waiting list ever recorded.
Thank you, Convener.
Yeah. Can we just get some clarity in terms of the difference now and what brought us to this situation? Why didn't we do what you're telling us that we're doing now over the last many years?
Well, I think...
What's different? What are we going to be doing? What weren't we doing over those period of years?
Well, I think when the revised system was introduced 2 or 3 years ago, clearly there were issues that developed, particularly in terms of the interpretation of social unavailability, which came to light, particularly after the situation in Lothian, Convener. And I think that's when a very intense examination took place of the practices right across the system.
Were the figures not available to Health Department officials? Were they not discussed with the Cabinet Secretary? I mean, my colleague who's not here today, Richard Simpson, first placed questions about waiting times and lists and codes in 2008-9. What was done? What would be the reaction of the Health Department? You weren't there. The Health Department to that sort of information, and what action would they take?
Well, as you say, I wasn't there, so I'm going to pass to Derek to answer, but I have spoken to my predecessor, Nicola Sturgeon, and she's very clear that there was very excellent information provided to her on a whole range of statistics, some of which I've mentioned, including on waiting times. But clearly, in some board areas, the interpretation of some of the rules was somewhat different from elsewhere. But I'll hand over to Derek, and he can give you chapter and verse of what was discussed and monitored.
I mean, the Audit Committee's report, I think, is actually quite clear on these points. And what we saw was a steady increase in social unavailability from its introduction in 2008 all the way through to a peak in December 2010. And there was a decline, slow at first and then quicker subsequently, down to more or less its current levels.
Yeah, I understand. I was just looking about the process. You know, when something like that happens, does somebody not look at the codes at that time? Did somebody not look about the variances, the problems there, and say, oh, these codes are not problem. There are massive variances here. What happens in the Health Department when something like that's brought to your attention? What did you do about it?
So there are a number of issues within that question. So firstly, there has been a range of scrutiny of these kind of issues over a long period. So Audit Scotland have done a number of examinations. They did raise some issues about variance in social unavailability, and they certainly raised some records about some issues about the recording of social unavailability. They didn't raise any issues with us about the level of social unavailability. And there was nothing in that pattern, that steady increase over 2008 to 2010, that leapt off the page to us and said, you've got a big problem here.
So it all happened within your health board that you were running along with the Cabinet Secretary at that time, and it wasn't a very real concern to you. It wasn't. You felt confident there was nothing going wrong. You didn't discuss it. What happened?
Again, this is in the evidence for the Audit Committee and in the report. There's this,
Mr. Feely, I'm just
quite clear here that we did not raise any alarms, any concerns about that steady increase in social unavailability over the period 2008 to 2010.
I know what the Audit Committee said, but what we as a Health Committee have got to look beyond that and say, well, can we trust the boards and the processes now, when obviously there was codes not entered properly, insufficient information put into the system, and indeed fraudulent practice in your health department?
There's no fraudulent practice in my health department.
What was manipulation? Is that too strong?
That took place in NHS Lothian, not in my health department. So there was a kind of, if you mean in NHS Scotland, then there was evidence of deliberate manipulation in NHS Lothian, but no evidence of deliberate manipulation beyond that.
But is that not bad enough? Because we've got to understand, surely, before we can move on.
The Cabinet Secretary said in his opening remarks, we recognise that what happened in Lothian was unacceptable.
Does that imply that the other practice, where insufficient information was not inputted, was acceptable or unacceptable? Is that acceptable or unacceptable?
It wasn't. There's no evidence that constituted any deliberate manipulation. So what there has been. You asked what's changing. So we've replaced social unavailability with patient-advised unavailability. That's to help bring clarity and transparency to the reasons why people are unavailable for treatment. Secondly, there is a bit of an assumption that social unavailability in itself is a bad thing. And that's not the case. Social unavailability in itself is not a bad thing. When it's used properly, is a proper and appropriate conversation between the health board, the clinical team and the patient about, let's try and find a time that's suitable for you, that takes account of the fact that you've got holidays or carer responsibilities or a whole host of other things. Thirdly, there is no question that our capacity in the NHS to record the reasons for social unavailability hasn't been as good as it should have been, and we're in the process of putting that right, firstly through the introduction of patient unavailability, and secondly through the increasing rollout of the track care system and better IT systems to help us record that information. So a number of things, a number of improvements in place to make sure that what happened in Lothian, as far as we can ensure it, doesn't happen again anywhere else.
You're not concerned about figures that are particularly high at one point and just plummet to, could be cutting 50% by 50%. That doesn't give it, is that not an indicator of?
Yeah, as said, Convener, there was nothing in that steady increase to 2010 that gave us cause for concern.
And the figures that have been placed in SPICE, monthly figures that have been placed, what do you glean from those figures that have been placed in SPICE, and bib number 548A4 in response to questions from Richard Simpson, where they look at the various codes and all of the numbers that placed in SPICE with the Cabinet Secretary. I presume what do you find from those monthly figures now?
I don't have those numbers in front of me, Convener, so I can't comment on them. I would be happy to write to the committee with an explanation of that, but I don't have the numbers in front of me.
Cabinet Secretary, have you had a discussion on these monthly figures? The Cabinet Secretary indicated we had a regular discussion on these figures. Is there any variances? Is there any issues with these problems? Is there a global picture? I'm trying to get the process here about what happened in the past, what's different now. People are sitting down every month, poring over these, providing reports to the Cabinet Secretary. If there's any variations, any peaks or troughs, then we sweep into action. So what have the monthly figures showed up over that period
Can I
of
just
time?
clarify the monthly figure, because we've placed a lot of stuff in space. Can I just clarify you're talking about the new figures, convener?
Yes, I think I am. Just placed in there, there's reams of them.
Well, we'll get reams
As
of
you
everything.
say.
We'll get reams of figures going back for years. Are we talking about
Yes,
the,
it's quarter ending
Right, well,
31st of March to the 30th of June
Yeah.
and 31st of December, years 2008 to 12.
2008 to 12. It's not the current figures you're
No, it's
talking.
after the audit report, though.
Aye.
So,
Right.
so we're introduced a new package. We're examining the figures. It's after the audit scandal and all of that. So we're into the new regime. And you told us earlier that you're meeting on a monthly basis with all of these figures. They are provided to you, Cabinet Secretary, are they not?
Yes, absolutely.
So
And-
what have the trends over that period shown us?
Well, the main trend has been the substantial reduction in waiting times to today, when the figures published at 9:30 this morning shows the lowest ever number of people waiting in the National Health Service in Scotland. I would have thought that's something the Health Committee would be very glad about.
Yes, you know, in the headline figure it would be, but in these figures it shows failing to attend figures in Glasgow have dropped by 50% or something between June and December 2012.
Well,
so does that ring any bells?
Well, I think what you'll
Any memories?
I think what you'll find is in Glasgow as in elsewhere, the new patient availability system, whereby patients are being contacted more often, where there has to be confirmation in writing and so on. Clearly, some patients are coming back and saying, actually, I'm not available. And it's kind of cleaning out the system, as it were.
So there's nothing in these figures that give you cause for anxiety
No.
or concern or action or consideration within you and the Health Department?
Since I came in September last year and looking at these figures, in the figures, and clearly patient availability has been replaced from the 1st of October, I think, with social unavailability. I think we've got a much more robust system in place. And obviously, in a transition from an old system to a new system, you will see changes, because clearly the boards themselves were doing a cleansing exercise to make sure that in terms of introducing the new system, the baseline for the new system is as accurate and robust as possible. So I'm sure, and I think we've explained that before, that exercise was being done. I mean, and also remember in Glasgow, you know, we've gone down from 11 IT systems, which is what it was until we came in, down to 3 IT systems and going to 1. And that also will be part of a cleansing process, because clearly when you rationalise and streamline and get into order your IT systems, as somebody whose background is in the computer industry, I can tell you what you do is you make sure that all the old stuff is dumped in terms of if it's inaccurate or no longer in situ. So clearly, in every health board, as part of this process and part of the implementation of the recommendations from their own audit, in Glasgow's case, is to clean up their database.
The variations between health boards not concern you? If they were making such pace in Glasgow, why are the others not?
Well, I'm going to bring John in, but I think when you're moving from 11 to 3 to 1 database, it's very clearly you're going to get a lot of cleansing, and it's a very big board area.
IT has been used as an issue in the past, which has been refuted by Audit Scotland.
We're talking
Yes,
we're talking about a set of statistics that I think you've got just now and that we don't have in front of us. We publish hundreds of thousands of stats on a monthly and quarterly basis, so it would be useful actually to talk about the same data set. But there are some valid reasons for why health boards do differ. If I take Glasgow as an example, Glasgow is a tertiary board which has got a number of specialist services. Compare that to Orkney, which exports patients to places like Grampian, exports patients to Glasgow, as an example. So not all boards do the same things. Orkney does not have cancer services, it does not have neurosciences. Glasgow does. So there will be differences in terms of the treatment rates, there will be differences in terms of the DNA rates, that's do not attend rates. So I think we must understand the basic nature of the function of each of the boards to be able to adequately comment on this. And I think, as the Director General has said, we would be more than happy to supply any commentary on any published set of statistics which are laid in spice.
Yeah, that may be a useful idea for all future figures that are laid in spice, because there are. I mean, I was trying to establish the process, which was a new process, which meant that the Cabinet Secretary, the health service head, were having regular meetings about this and had all the explanations and variations and had been completely confident about these. That's the new regime.
If we are not confident about a set of statistics, we take this up with the local management team. This is a regular discussion which is held with each set of chief executives on a monthly basis, with the Director General chairing that meeting, and indeed with the Cabinet Secretary chairing a similar meeting with chairs. And these statistics, which are published, open, transparent to everyone, are discussed at those meetings.
Have you been in a position where you felt you had to raise the variances with the various chief executives of the boards in the last few months?
We seek to understand what's happening in each board. So, for example, if we spot that there is an issue with, let's say, the number of cataract operations that are performed in a board where it's perhaps for that quarter unnaturally low and the waiting list is growing, then we raise that with a particular board. So, give you a good example for that. We know that the demand for cataracts is growing. I've already given you an idea of the 10-year history of that growth. We've got an ageing population. We have taken the decision in the course of the past quarter, in discussion with boards, to significantly increase the capacity in the Golden Jubilee for both hips, knees and cataracts. That was as a result of the conversations that we have with boards to understand what pressures they're facing with that ageing population and with the increased demand. So that's a prime example of how we have that debate with boards. So
that's a normal occurrence to discuss these variations?
It's been a normal occurrence for the past 10 years.
Yes. I think you've said it all then, because, you know, if it's a regular basis for the last 10 years, why didn't address some of these issues that we've been discussing earlier? So what's changed?
Well, there's a lot changed. First of all, the data that's collected has changed. The social unavailability has been replaced with patient unavailability, and all the things around about that, about requiring a letter to go out to the patient confirming their unavailability. The whole range of things have changed as a result of the recommendations made and implemented.
One of the, you know, being referred back to your GP, has that increased recently in terms of your numbers?
The number of people or number of patients referred back to GP has increased over the course of the last 2 or 3 years. This, in fact, was an Audit Scotland recommendation. If you remember at the PAC meeting, I think the committee raised some issues about patients in Highland, as an example. Now, patients in the system should be formally reviewed every 13 weeks. Okay? And if there's no prospect of treatment, then return to GP. Many boards took a rather benign view of that and decided to keep patients on waiting lists until such time as they were ready for treatment. And you can probably understand that, let's say, in a rural setting, like the Highlands or like Grampian, where there are many folks involved in crofting and farming and the fishing communities. But there has been an increase. The Cabinet Secretary has outlined that more rigour was attached to the scrutiny of the number of people on that list, in line with that Audit Scotland recommendation. And the number of patients returned to GPs over the course of the last 6 to 9 months is definitely greater than the period before that.
Drew Smith.
I wonder if we could just... I think going back to some of the questions that Mr Doris was asking around, and we discussed some of the issues of capacity and pressure in the health service, why should there be a correlation between social unavailability and areas of pressure in the health service? We can well understand that these pressures create capacity issues in the health service, but why should there be such a strong correlation with rising unavailability of patients?
Well, I didn't say there was a correlation between social unavailability and pressures. I was answering a different question. There were two separate questions. One was about social unavailability, the other one was about pressure. So I've never said...
Because the Audit Scotland report said social unavailability tends to be higher in specialities with more pressure on capacity.
Well, the speciality is obviously, because very clearly, a very good example is what John has already outlined, where sometimes people have to travel quite a distance from the north of Scotland to get very specialist treatment, say in Glasgow or Edinburgh or at the Golden Jubilee. And therefore, where you have long distances involved, very often patient unavailability is greater than what it would be if the facility was just on the doorstep.
Can I perhaps refer you to previous evidence in this, and it's interesting. Mr. Calderwood's Chief Executive of NHS Glasgow provided some evidence as follows. It is clear that Audit Scotland has not identified manipulation across the NHS in Scotland. As that's Robert Calderwood, showed with the orthopaedics example, if the report had used the July 2011 figure, the report quoted the month of May 2011 saying that the 40% waiting list was socially unavailable, 145 patients. If it had quoted the month of July, that would have dropped to 42. Now, the reason that Mr. Calderwood raised that example is that sometimes consultants can become unavailable themselves to provide treatment because they're perhaps sick, they've moved off, and there's an interregnum between appointments of consultants. So from time to time, will get a small spike in the number of patients who are unavailable because they do not wish to travel to another hospital but prefer to remain in situ waiting at their own hospital until such time as a new consultant becomes available. And that usually is a relatively small period of time, as per the example of orthopaedics in Glasgow, a month or two.
I mean, you quote Robert Calderwood, and quite right to do so, and I think people could understand his perspective on this, but I think we should also say the first recommendation from the Public Audit Committee report tells us that the IT systems did not allow sufficient data to be recorded in order to establish whether codes were being applied appropriately or not. So, I mean, I don't think the data actually proves one way or the other. So, I mean, is your explanation, because we did raise the Glasgow example a few times and this issue around the orthopaedics at Glasgow, where at the Western, in Glasgow, where we had hundreds of patients who were apparently all unavailable at the same time. I think it was in January and February 2012. You're saying that was because of the unavailability of a surgeon that was responsible for that, or sorry, a specialist of some kind?
Yeah, I think Mr. Calderwood had two examples. One was for ophthalmology, and the other one was for orthopaedics. I can't remember if which was which in terms of the unavailability of consultants, but it's clearly in the records of the 13th of March.
And I think this is against the background of where, in certain areas, there is now very specialist consultants. You know, it's not just the speciality maybe in one particular discipline, but it might be in a very narrow aspect of that particular discipline. So there's a whole range of reasons why people would not be available, or in some cases, the consultant might be off sick, and he might be the only consultant who does that very, very narrow speciality. You're dealing with a very complex system. This is, you know, not the Royal as it appears every Sunday night or used to in the telly. This is a much more complex, modern health service.
I think my constituents would understand that, and I think people waiting for treatment for painful conditions at an orthopaedics unit would particularly understand that if they then discovered that they'd somehow been marked as unavailable, and it suggested in Parliament that a large number of them were all on holiday at the same time, when I think clearly that was not the case.
I mean, the Auditor General investigated specifically, and as you know, spoke to a number of people and investigated themselves why that spike was there in Glasgow and found nothing untoward. And they interrogated the non-IT system because they made the comment that the IT system didn't collect enough information to do the analysis. So they did a paper exercise and they didn't find anything untoward in that specific example. We've been through this 3 or 4 times.
the Cabinet Secretary will probably understand why people would be concerned about any correlation between unavailability and pressures on capacity. And we did discuss A&E earlier as well. So, I mean, I presume he's aware of the information we got from RCN this morning that said there are not enough staff, beds or resources within the system in the right places to deal with increasing numbers of patients attending A&E departments. Now, why do you think, what would be the motivation of RCN in bringing that to our attention this morning?
Well, they're not saying anything new that we're not saying. I mean, I started off by saying that one of the problems with A&E is, apart from the increasing demand, which has risen very dramatically, as we know, right across the UK in the last 10 years, apart from that, very clearly there is the complexity of the cases they're dealing with, but also, if you look, you need to look at the flow through the hospital. Now, if you take the winter surge period, when things at A&E were the most challenging across Scotland as a whole, the College of Emergency Medicine in Scotland did an exercise looking at the time people actually spent in A&E, and even during that winter surge period, according to them, the median average time people spent in A&E was actually under 3 hours. The problem arose in some hospitals where there weren't the beds available in the wards at the time they were needed when people were discharged from A&E. Now, if I can just give you an example, I think I'm right in saying this is Edinburgh Royal Infirmary, where one of the recent changes there is much earlier discharge, because patients are ready for discharge but haven't been discharged for various reasons. The consultant may be doing his rounds later in the day or whatever. But if you look at Edinburgh Royal Infirmary, in recent times, they've increased the percentage of daily discharges from 6% in the morning to something like 21% in the morning. And that has a material impact, beneficial impact, on the availability of beds of people discharged from A&E who are going to a ward. So one of the areas that we're looking at, and working with the College of Emergency Medicine and indeed our other colleagues, because obviously it's consultants who service the wards, is improving the discharge situation. Indeed, one of the exercises we did jointly with the College of Emergency Medicine showed that probably up to a quarter of people in hospital were there above and beyond the period when they could and should have been discharged. Now, they might not have been discharged because the consultant wasn't available in the morning, only available in the late afternoon, or because they were waiting on pharmacy products to discharge the patient, a whole host of reasons. So discharge is an area, and better management of discharge in the wards is one of the ways in which we can tackle the issues in A&E, because the issue isn't, if you analyse the issue properly, the issue in A&E has not actually been internal to A&E per se. It's been about a third of patients seen in A&E on average are then admitted to hospital, and the problem has been they've been waiting on beds to get admitted, and by improving discharge we can improve the availability of beds and therefore reduce the number of people waiting for any length of time after discharge from A&E for a bed in a ward.
Just turning to kind of some of the solutions that have been offered for this whole problem, and, you know, we're also aware of the action plan that's now in place to assist us in getting people through A&Es and indeed through the rest of the hospital. As you say, I mean, one of the questions RCN have got this morning is they're asking for more clarity about, because obviously the RCN's perspective is that you would need to have more frontline staff available, nurses and allied health professionals, in order to achieve the kind of results that you're looking for. And that's not necessarily clear that's what would happen. So what they're asking for then is where is the money that is behind the action plan coming from? Is that coming from elsewhere in the health budget, and if so, where? Can you?
The £50 million for the emergency action plan, I mean, we are increasing the territorial board's budget, as you know, substantially above inflation, substantially above the Barnett consequentials overall this year and next year, and therefore the money available there's new money. Absolutely, there's new money. You know, the budget for the territorial boards is going up substantially above the overall increase in the Barnett consequentials.
So it was money that was already in the health board budgets for this year, or it's new money from out with the health board budgets? I'm just want to get some clarity on that.
No, the budgets for this year, the new year we're in, and next year, show a deliberate decision to increase substantially the budgets for the territorial boards. One of the reasons for doing that is to address the A&E issue, and the £50 million comes out of that additional money.
Could I just finally, Convener, ask about the confidential alert line? Cabinet Secretary, where I've got an interest in, and I think we're all very supportive of that process and hope that it does lead us to some solutions in this. But there was some press in the weekend around what process you then that you then enter by calling up the alert line. So could you maybe just take us through that? If you phoned the alert line this weekend, you'd been on shift all week and phoned the alert line and, for example, said, I've been encouraged to mark somebody as unavailable when I don't really feel that would be the appropriate thing that should happen, or any other complaint you might have in the health service, would that be treated? How is that then escalated from the call? And the suggestion has been that people are simply being told, well, you should raise it with your manager or even your trade union, which was kind of taking us back to where we were to start with.
Well, I saw the comments from Kim Holt, and I have to say I disagree with her when she says it's a waste of time. First of all, can I say we had a number of calls from south of the border. Now, by definition, we can't deal with problems in the English Health Service. Were it the case, we would certainly be doing things a lot differently from what they are doing south of the border. So I don't know if she's referring to those cases or to other cases. I'm seeing Kim, I think it's later this week or next week, and I will ask her for more information on that feedback, because clearly if she's getting that feedback, that would be concerning to me, because I want to make sure I set up this whistleblowing line to make sure that action was taken, and it's run by an independent organisation called Public Concern at Work. I myself have asked for information on the outcomes of the calls. Obviously it will be anonymised information, but I've specifically asked for a monthly report on the outcomes of the calls. Now, it just started last month, so obviously I would expect it'll be 2 or 3 months before you see the outcomes, because some of these may be fairly protracted procedures. But I have specifically asked for that report right at the beginning, because I want to be sure that we're not just taking the call and then recording it and then not taking up the necessary follow-up action. I want to be absolutely sure we're taking up the follow-up action, and that's why I've asked for that report. I will ask Kim Holt for more detail on the people that she has spoken to find out, why that, to try and find out why that happened, because clearly we've set up this whistleblowing line so that it is effective. I don't think, that you can reach a conclusion it's a waste of time 6 weeks after it's been established, and on the basis of a survey of possibly 3 or 4 people. I think we've got to give it much more time, and I specifically am looking at its effectiveness, and clearly there's no point in having it if it's not effective, so I'm taking steps to make sure that we ensure that it is effective. There may be cases where the most appropriate action is to take something up with a line manager. There may be cases where that is the appropriate advice. That doesn't mean to say the whole whistleblowing service is then brought into disrepute. If that's the appropriate advice from Public Concern at Work, who are experts in this field, they're not part of the National Health Service, it's an independent organisation, and they're using their professional expertise. So if that's their professional advice, they must be giving that advice for presumably a very good reason. But I will talk to Kim, and we will be looking, and I specifically have asked for information on the effectiveness of the line.
I want to stick, if I may, with the RCN report for a bit. Now, Cabinet Secretary, you said that you mentioned the winter surge in A&E, but the RCN briefing to us out with A&E says that the NHS in Scotland is facing a perfect storm of all year-round pressures. According to their survey, 9 out of 10 nurses working in NHS hospitals are experiencing pressure in beds all year round, not just the winter surge. And at another part of the report, they refer to the increasing pressures, particularly due to demographic changes and so on. And as you said, the situation is changing very rapidly. So there is a question as to whether we truly do have enough staff, beds, resources to provide the high quality care within the expected waiting times that have been decreed. Can I have your comments on that, please?
Well, obviously these are pretty perennial problems in terms of the National Health Service, and what was very clear is that we needed a more robust approach than had been traditionally the case, and that's why through John's leadership and Derek's leadership we've introduced the workforce planning tool and made it compulsory as of April for every board. And the whole purpose of the workforce planning tool is to ensure that not only we have the right number of staff, but we've got the right mix of staff in the right place at the right time. And that's the purpose of it. And the RCN and other unions have been working very closely with us. And certainly the feedback I've had via Teresa Fife from the RCN is that this is the right way to deal with that issue. And you've probably seen this morning the very welcome figures in terms of the NHS staff. It's, again, is up. Number of qualified nurses is up as well. So we are dealing with that precise issue in conjunction with the RCN and our other partners. In terms of the issue of beds, as you know, I announced last month the introduction of a bed capacity planning tool. And again, that's to make sure that we get the right number of beds in the right place at the right time and we manage the bed resource properly. And there are examples of where we've actually increased the bed capacity because there has been a recognition. But more generally, and there are specific areas, for example, one of the reasons we face challenges in the Lothian area is because the planning that was done 10, 12 years ago for the new Edinburgh Royal Infirmary grossly underestimated the increase in population in Edinburgh by about 20%. And that's why we've had to create additional capacity on top of the ERI in Edinburgh to deal with that additional population. But in terms of the general point, you know, we recognise the pressures on the National Health Service primarily because of the ageing of the population. And to get that in perspective, over the next 20 years, the number of over 75-year-olds in Scotland will double. And 1/5 of everybody born in Scotland today is likely to live until they're at least 100 years of age. And I think that puts into perspective the challenge, not just today's challenges, but tomorrow's challenges for every health service in the developed world.
There's a hope of the NHS coping into the future.
Yeah, absolutely. I think we're coping just now. I mean, today's figures show, you know, that we are coping, but more than coping, we're delivering. You know, a record low for the number of people on waiting lists now, and that's against a background of demand and throughput rising every year in the National Health Service. You know, I've mentioned A&E figures. If you look at A&E in Scotland 10, 12 years ago when this Parliament was formed, there were just over 1 million people presenting to A&E every year across Scotland. There's now 1.5 million people presenting to A&E every year. Now, obviously, there are various reasons for that. The complexity of comorbidity associated with the ageing of the population is one of the major drivers for these pressures. But we recognise the pressures. That's why we're working with all the Royal Colleges, with the RCN, with Unison and all these other people to address these issues. But I mean, there is no doubt we face major challenges, primarily but not exclusively, from the ageing of the population and the comorbidities associated with that.
So, work in progress. I was interested in Mr. Conaghan's comments about looking at other aspects of the health service and you know, assessing what could be done differently. As you know, this committee has been looking in very great depth recently at the scrutiny of medicines, and it has been raised with the committee that there isn't the same scrutiny of other procedures, perhaps, you know, other issues within the NHS. Do you think there is a case for doing the sort of detailed scrutiny throughout the NHS that currently is done on medicines, you know, via a body like the SMC?
Can I just say a word or two and then pass to John on that? I don't actually accept there isn't that level of scrutiny elsewhere. You only need to look at the scrutiny on waiting times and waiting lists that's gone on over the last 12 months. And I don't think anybody who's being realistic can say there has been a lack of scrutiny. We've had audit reports for every health board in Scotland. We've had a Auditor General report. We've had the Public Audit Committee. And we'll get this committee all examining the issue as well as the work we're doing ourselves. So lack of scrutiny hasn't been the problem in relation to waiting lists.
In terms of individual procedures,
yes,
and assessment of
thank you. If I could say that perhaps one of the things we don't do as well is we don't broadcast perhaps enough of what we're doing around transforming the patient pathway. And I can give you some idea of the activity we've been involved in over the course of the last 3 or 4 years, we've focused on 5 key changes to that patient pathway. First of all, improving referral and diagnostic pathways, treating day surgery as the norm, thirdly, actively managing admissions to hospitals, fourthly, actively managing discharge and length of stay, and fifthly, actively managing follow-ups. And all of that work and all the associated redesign and scrutiny of how patients move through the system is, I think, very adequately captured on our 18 weeks referral to treatment standard website. And if you go there, then there's an enormously rich amount of detail that captures, I think, the point that you're actually making.
Right. I think finally I would ask, with the alert helpline, has there been, you perhaps don't know yet, it's perhaps too soon, but has there been any noticeable increase, noticeable calls there from RCN, from nurses? Because I am concerned, this report was presented to us today, there are still obviously serious concerns within the nursing profession. Has that reflected so far?
Well, it's too early to do any kind of analysis. I think you need to probably let it go for 2 or 3 months to get any meaningful analysis. But one of the things we're doing is, for example, advertising the line number on the pay slips of every member of staff who works in the National Health Service. We're putting up posters, we're advertising it widely throughout the National Health Service. And I know some people criticised us before we did it, saying we wouldn't get any response, and then criticised us after it, saying that it's ridiculous. We've had 35 people in the whole of the health service employing 156,000 people, that we've had 35 complaints. So I suppose you can't win with some folk.
I certainly would be very interested to find, to hear the sort of breakdown of the calls to that helpline.
And we'd be happy to share that at the appropriate time. Derek?
Just to add one thing that might be helpful to Nanette Milne, and that is, while this work is really important, and the feedback we get from the alert line absolutely vital, it's not in itself enough. And so that's one of the reasons why we've been working up this document, which we'll release in the middle of next month, called our Workforce 2020 Vision. And we spoke to 10,000 staff in the NHS. 10,000 staff gave us their views about what it's like to work in the NHS in Scotland, and we asked them about the values that they had and what was really important to them. And the majority of those 10,000 staff were nurses, as you would expect. And so it's important to hear all of the voices, or as many of the voices as you can, not just the people who feel bad enough to phone the alert line. And so we're trying to do both of those things.
Forward to that report.
I think that was important to put that on the record, because right at the heart of this, we're having a political debate about targets and whatever. When we speak to the Royal College of Physicians, they give us a similar message, the RCN and some others. And, while waiting times and targets are popular, and very popular with successive Scottish governments, they are not as popular within the health service themselves, who, if it was left up to them, would be identifying maybe different priorities. And I think we shouldn't forget that. I don't think that's part of the debate about, there is another side of this debate about, well, our focus on waiting times and those who deliver the service. And maybe I think we hear a bit about that, about the change that needs to take place, the preventive strategies, the shifting of budgets are crucial about how we deliver that service. Just not the care pathways, but there is an issue there. The people who are not in this room around the table have got a strong view on waiting times. Gil Patterson, followed by Aileen.
Thanks very much. I wonder if you could put in context what waiting times actually mean, and quantify it in terms of since maybe give us some figures 10 years ago. I know you're saying, the Cabinet Secretary, it's an all-time low. What does it actually mean in terms of numbers and percentages?
Well, for example, if you take the bang up-to-date figures today on the guaranteed treatment time, 99% of the 93,000 patients covered by the period of that report were seen within and treated within the guaranteed time of 12 weeks. So it's 93,000 patients were the kind of catchment for that. But John's been in the health service much longer than me, so if you've gone back 10 years, I'll defer to John. Of course, he's much younger than me, I should stress, but he's been in the health service much longer than me.
I can also go back 20 years if you fancy that. About 10 years or so ago, the focus was on waiting lists in terms of numbers. And back in March 05, as an example, we had 112,000 patients on our waiting list. Now the Cabinet Secretary has referred to the latest statistics published today, which shows just under 53,000. So that shows you the significant change. But back in 2005, we had patients who were waiting many months for, in fact, sometimes years, for an outpatient appointment and indeed subsequent inpatient and day case treatment. And in 2005, we decided at that point in time in the NHS to turn our focus to tackling waiting times, as well as looking and keeping a grip on waiting lists. And the Cabinet Secretary, I think, has outlined where we are today in terms of the numbers of patients waiting over 12 weeks. But to put that in context, we also need to look outside Scotland. We need to put it into an international context. And I'd like to refer you to a recent report, OECD report, which compared Scotland with the other home countries and indeed across Europe. And Scotland's position in that analysis was exceptionally good. Out of all the home countries, against the major procedures like hips, knees, cataracts, etc., common type of operations, it generally performed better than the other home countries. That report, which was dated 2010, will be repeated shortly.
And I think Derek's got some additional information.
Just add this because it partially, I think, refers to something that Drew Smith was mentioning earlier. If you look at where we were on inpatient and day cases, and you look at what we call the unadjusted median, so that's everything in, all unavailability, the whole thing. In March 2008, when social unavailability was at its lowest, the median unadjusted wait was 39 days. In December 2010, when it was at its highest, the median wait was 34 days. But it just shows you that there's no direct correlation between, in general terms, the amount of time that people wait on average and the extent to which there's social unavailability. And that trend has continued steadily down. I mean, if you think about where we were 10 years ago and where we are today, there's just no comparison between the two. And that is, as the Cabinet Secretary said in his opening remarks, down to the huge efforts that 150,000 NHS staff have put in to benefit patients in this way. And that I think, is the connection between the two points that the convener made. That as long as we always remember that we're doing this for patients, this is, the statistics only tell you, only help paint the picture in terms of what's happening for patients. And I think there's no question, to come back to your point, that patients get quicker care now than they did 10 years ago.
Yeah, on that theme for the future for patients, I know you explained, Cabinet Secretary, that people who present at A&E is up at 1.5 million per year. I wonder if you've taken any account of, or if you're assessing the impact of the social reform, how that's going to impact on the service. Is there any work being done in that?
Yeah, we are looking at that. I mean, benefit reform, I mean, a very obvious and immediate one is obviously the issue around the additional workload for GPs in providing letters to the Department of Work and Pensions. And obviously that's an issue both Nicola Sturgeon and myself have raised directly with Ian Duncan Smith, and we've yet to receive any kind of reassurance in terms of how that may be improved, because clearly that is in a number of, particularly in GP surgeries in the more deprived parts of Scotland where there are higher levels of unemployment. Very clearly that is putting major pressure on GPs in those areas. But more generally, I think myself, from my own experience as an MSP, let alone as the Cabinet Secretary for Health, that the additional stress being placed on people through worry about their income, if they're relying on benefits, will have the impact of making additional pressures on the NHS, not least on mental health services, because I do think this is affecting people's mental health as well as their physical health, the stress they're being put under. I mean, I had somebody recently at a constituency surgery of mine, she'd been left with £18 a week to live on by the Department of Work and Pensions. I think that would put anybody under enormous stress.
Yes, thanks for that.
Just on that theme, I thought, has any work been done about the people and the social availability? Does that impact on a particular group of people? We've got another session coming up on community transport, and has any, you've got all the figures, you've got the people, the groups and whatever. Have you taken to do any work yourself to determine whether those sent back to the GP, those who couldn't make it because it was in Clydebank or wouldn't move or whatever, transport barriers, to ensure that inequalities are not being affected here, that poorer people are more likely to be on those lists where they have been sent back or failed to attend or whatever?
We have looked at that quite extensively over the years. And in fact, if I can refer you to one of our existing, in fact, newer policies, which seeks to redress that very issue, and it's the Detect Cancer Early programme. And it's quite interesting looking at the patients who come from, let's say, the lower income deciles, as those who are perhaps less likely to access healthcare. And that's precisely where we're bending, let's say, more effort to encourage patients to come forward, see their GP, visits the facilities, such that we increase the profile of the NHS and the access for those folks. And indeed, our Detect Cancer Early programme has got significant extra funds, about 30 million or so over the course of that programme, to invest in that area. So yes, we do look at it, and we do have some action in that area.
Detect Cancer Early has been in place a couple of years, is it not?
It has. The programme started rolling out, though, basically over the course of the last year.
I haven't done any work in respect to the situation we had about the codes or whatever. It just seems, likely that the people who would be more likely to fail to attend or not go through that system are more likely to be in those groups. That might be wrong to suggest that, but they're not sufficiently engaged in the first place, so and harder to reach. Would it not be worthwhile doing some work there to find out whether those people have been disproportionately impacted by recent events? I'll not call it a scandal.
There has been some work done in the past about did not attends, and so we've been targeting some of the reminder systems we've got in place as a result of that. But I don't think we have ever done any analysis of unavailability, either medical or social for that matter. And we could certainly undertake to see what could be done. It would be
leave that up to the Cabinet Secretary, of course. Yeah. I've got Aileen MacLeod.
Thanks, Convener. Can I start, Cabinet Secretary, by welcoming the latest stats this morning that show that our waiting times are at a record low, and also the fact that the number of qualified nurses are on the up. And I think it is important to remember the progress that has been made in the last 10 years in ensuring that our patients across Scotland get quicker care, and certainly for our 153,000 staff in the NHS. They are to be commended for their efforts in that regard. Can I pick up on what you said at the beginning of your statement, the fact that we've been through the most thorough investigations into our waiting times, with Audit Scotland receiving some 273,000 transactions between April and December 2011, and the internal audits interviewing 400 staff and reviewing a further 200,000 transactions between January and June 2012. We've got the Public Audit Committee has done its report. It's made a number of recommendations, which I'm conscious that the government will be responding to in due course. And as Cabinet Secretary has said, that by the end of this year, you'll have all the reports on the follow-up audits by the internal auditors and the Audit Scotland. So, can I therefore ask then, where do we go from here? I mean, what are the kind of improvements that we need to be looking at in the future, so that we can identify the pressures and address those areas where there may be issues? And I know this morning we've touched upon areas like the £50 million unscheduled care action plan, and also the new digital ward that's been trialled by NHS Borders.
Well, I think it would be true to say, we have a very wide-ranging strategy in terms of improvement across the whole field of activity in the National Health Service. We've been talking this morning, obviously, about waiting times and improving the flow of patients. We've been talking about the emergency and unscheduled care plan. We could go on to, for example, the £45 million we've just spent last year on research and development, and the benefit that's bringing. For example, a lot of that money was spent on exercises over recent years on informatics, and as a result of work done by the informatics research team, the percentage of amputations resulting from diabetes has dropped by, I think the figure is 40% in recent years. Now that's a very, very good example of where original work, innovative work, scientific work can help us enormously in improving the health of the nation. I could give you many other examples of where we're doing that, and I think the role of science and technology and innovation is absolutely essential to providing a health and to realising our vision for 2020. The family nurse partnerships is another example of the kind of innovative work being done in Scotland, where people are coming from the rest of Europe to see what we're doing with the family nurse partnerships. I could give you a whole list of initiatives that were being taken in various parts of the country. I mean, I'll just mention one convener. I was down in East Ayrshire about a month ago, and visiting a telecare pilot project as part of a conference. And we were talking by remote control from Kilmarnock to a patient in Dalmellington, 25 miles away. And that patient is very typical of patients we're dealing with in terms of long-term conditions. She's got COPD, she's got diabetes, she's got a number of conditions wrong with her. She's in her mid-70s, and until a year and a half ago, she was never out of hospital. Then she had an iPod installed in her home as part of the telecare pilot. There was another 19 patients in that GP practice involved as well. And she speaks almost every morning to the GP practice nurse, and she takes her own temperature, she takes her own bloods for diabetes and various other measurements. And in the last year and a half, she's never been back in hospital, and her health is much, much better. She's back at the bingo. And if you look at the 20 in the pilot across the board, there's been a 70% reduction during that pilot period in hospital admissions amongst that group. That's where we're taking the health service. That's the kind of initiative we need to focus in on.
Thank you.
Richard Lyle.
Good morning, Cabinet Secretary. I'd like to turn, I've got several questions for each of you. I'll first turn to John Connaughton. Can I go back over a point you were making about, firstly, cataracts, how many patients have been treated in the last year? Tremendous increase. Can I say that I have been one of those patients? At the end of the year, last year I had this eye done. Prior to that, I had to wear glasses for 30 years. I could have hardly seen you, even though you're 5, 6 feet away. And at the start of this year, I had this eye done. Now I can see 40, 50, 60 yards away. Unfortunately, if I want to read something, I think I have to put on other glasses, so thank you for that. But can I turn to, and I was impressed with the service that I got from the National Health Service, and also speaking to the clinicians that they were under the factor that due to holidays, etc., there are times when they're there or not. Can I turn to the comment you made earlier about Robert Calderwood's comment? And can I remind you, it was highlighted, and this is the comment he actually made, highlighted in April 2011, 924 patients were on the waiting list at the Western Infirmary in Glasgow under the term social unavailable. Had Audit Scotland picked July 2011, it would have found that the number was 343. That's nearly a third. Two-thirds less. There was a very selective approach where one waiting list was picked out of 8 in 1 month. So that was a comment. Would you like to revise on that comment?
Well, I think that comment's obviously fairly accurate. I think you've lifted that straight from the last evidence to the PAC. And I think I recall that Mr. Calderwood made that comment to illustrate how things can change so swiftly, because obviously I think that was against a background of a consultant or a service not being available locally, and folks simply just saying, I'd rather stay and be seen in Stop Hill rather than travel, let's say, to the Victoria. I think we're also lucky in having the Golden Jubilee on board, and recently we've announced another £1.7 million expansion in the Jubilee to increase the number of cataracts there by approximately 200%. And if I take a look at this, we've achieved two things. Let me just stick in cataracts, which I think you know quite well. But we've achieved two things here. We've not only achieved a reduction in waiting times and waiting lists, but we've also managed that against a significant increase in capacity. So, year 2000, the median wait was just under 100 days, and now the median wait is about half of that. 19,000 cataracts, 2000, and now 32,500, and all of that, as I say, against a guarantee of treatment. So I think Mr. Calderwood's remarks are accurate, and I think he's put in context that you shouldn't really just take a look at selective and isolated statistics.
Can I turn to the Cabinet Secretary? You have specified and you've said that over 1.5 million people are now visiting A&E. Nearly half of the population of Scotland is constantly in touch with the health service one day. And if I go back over a previous life, I also had experience for 2 years of working with out-of-hour services already, you know, and experienced quite a lot of visits to all the A&Es within the Lanarkshire area, both Ayrmyres, Wishaw, Monklands, and basically the situation. Would you agree with the comment that most people, in the first instance, want to go to an A&E because they know that they will be A, treated well, and B, treated there on the spot as soon as possible?
I think it has become the default position for people when something goes wrong, particularly out of hours, then they think immediately of A&E, but that's part of what we've got to try and address, because very clearly there are people turning up at A&E who are not really there for an accident or an emergency and would be more appropriately treated through other means, such as going to their GP if it's not something urgent, or through the NHS-24 service, or by going to a minor injuries unit, of which we now have a number. So the whole management of, part of this is managing the demand and looking at the demand profile right across the board in the health service, but particularly in accident and emergency. And if you look at some of the innovative work, for example, done at Ninewells in Dundee, where they have segmented those who present to the hospital in a way that manages those that are really urgent cases that need to be dealt with right away. It might be life-threatening cases, as opposed to those who are dealing with fairly minor, non-urgent ailments. And many other boards now are doing something similar in terms of how they manage people who present at the hospital, at the A&E department, to make sure that those that are really at an emergency are dealt with much as appropriate, whereas those who are presenting with more minor ailments are also dealt with appropriately, but perhaps not as urgently.
And my last question to Mr. Feely, the Cabinet Secretary made a comment earlier on that you have data coming out your ears. In amongst this data, or go back to when this, I wouldn't call it a scandal, I would call it a situation happened. Would you agree or not agree that in some ways some staff may have not been trained correctly, may have miscoded through not knowing where to put someone because someone's unavailable? I attended my dentist. I've done well the last couple of months. I attended my dentist last week for the first time in 8 years. And I noticed on the wall they had 52 appointments were missed the previous week by people not turning up. And the point I referred to in regards to my cataract operations, I did get letters to say, if you're unavailable, phone this number or whatever, or if you're okay, come along. And I didn't want to miss them, even though I was planning on going on holiday. But in regards to the other comment that was made by, I believe, Sandra Hurst of Audit Scotland, waiting time targets in themselves can be a good thing. Obviously, they help people to focus on the issues that matter to patients. But they're also a good barometer of when there can be a capacity pressure. If a service is failing to meet the target, there is something going on in the system. In a sense, a failure to meet a target is not necessarily something to get beaten up about. It is an alert what is happening in the system. In regards to comments you made earlier on, Mr. Feely, where you weren't beaten up about the fact that the unavailability had risen, was that not just because of the fact that the system was bedding in? Could it also have been that people may have inappropriately recorded it wrongly through lack of training, and now that we have the new system in place, we now know exactly everything's on the table, and the comment that the Cabinet Secretary has made that the data which is now coming out of our ears will now show what is happening. Can I compliment you on the reduction in the number of people in the waiting lists? Can I compliment you on how well the staff in the health service has worked? Having personally been there 2 years ago, I would recommend anyone to go to an A&E to see how quickly and how well they do work. And also, can you say that we're getting to grips with this?
Yeah, I mean, I think in the evidence that some of the chief executives gave in the Audit Committee, and also I think in some of the findings from the Audit Scotland report, they definitely identified training as an issue. And so I think it is entirely realistic to say that that was a factor in all of this. On Barbara Hurst's point about targets, I again reflected to your colleagues on the Audit Committee that one thing that targets do is they focus attention. And I think so long as you're constantly striving to have the right targets and you don't have too many, then targets have a place. It's not always the answer is to set a target. There are other things that we do where we don't set targets. We try other means of improvement. Today in Glasgow, we've got the second learning session of the Early Years Collaborative. We're trying to improve outcomes for young people. Completely different approach to improvement, but still trying to improve. So targets have their place, I think. Two things I think are important if you're going to set a target. One is that you accompany it with the kind of things that John Conaghan was talking about around redesign. So it has to be you need to provide people with the means to deliver on the target. And the second thing I think is that you have to think about, so what are the principles that you're going to apply as you performance manage all of this. And one of the big strengths we have in the NHS in Scotland, I think, is our partnership working. So one of the things we sat down and did with the partnership organisations was we agreed some principles for performance management, and one of those is that we put patients first. Patients come before the target.
Thank you.
Jane Baxter.
Thanks, Convener. Morning. I'm new to this committee, but I've been listening with great interest to all the information that's been getting shared this morning. And I note that the Public Audit Committee felt that the information provided to the members of NHS boards should be sufficient to allow non-executive directors to provide an effective challenge function. I've had the pleasure of being a non-executive director of an NHS board, and I have to say, speaking personally, sometimes the information we were given was very impenetrable and quite copious. And I just wonder whether any guidance has been given to NHS boards about how they can translate all that information of the sort we've heard this morning into knowledge and understanding, because that's what needs to come out of this, and some consistency right across the country. So have the boards, is there any guidance to boards and to managers at board level about how this information can be presented and interpreted?
If you take the last chairs meeting, this actually was one of the discussions we had with the chairs about making sure the non-executive directors fulfil their scrutinising role and know what questions to ask. And we gave them actually some indicators of the kind of questions that should be asked, because that is the role of non-executive directors. It is to hold the executive to account in the health board. And I would like to see them being more robust, quite frankly. One of the things I've initiated, my first one was with Ayrshire and Arn Health Board non-executive directors, as part of the review process, is actually holding a bilateral between myself and the non-executive directors, with none of the executive directors present, so that they get the message very clearly that I expect them to hold the executives in the health board to account. And that means you've got to probe, you've got to ask questions. If you're getting information presented in an unacceptable fashion, as you described in Fife, then you say to the executives, this is not acceptable. We want it in a much more understandable format. That is the job of the non-executives, and I would like to see the non-executives take a more robust approach.
Glad to hear you saying that. Thank you.
Any other committee members? Drew Smith.
We've got the advantage this morning of working in real time, because we're obviously following the waiting times new information that the Cabinet Secretary has given us. I wondered if you could also maybe give us the detail of the A&E target, where we've changed. I think we've now downgraded from 98 to 95%. Did we meet that this time, either on the old target or the new target?
Well, it's not a downgrade. What we're saying is we've got to get to 95% before you get to 98%, obviously. And a number of boards are at 98%, a number are at 95%, aiming towards 98%. Across Scotland as a whole, this morning's figure is 92%. So that is not as high as I would like to see it, but it's certainly moving in the right direction. We need to get to 95 and 98%. That's our objective.
Thank you. Jackie Bailey.
Thank you very much. It just teaches us that we should be careful in the claims we make. Might I also observe that the number of nurses having been cut originally by 2,000, I understand the figures is that cuts 1,500 or so. I don't regard it as good news to simply replace a quarter of all the numbers that you've cut, but hey-ho. Can I focus on the codes that the convener raised with you? There are a variety of codes. I'm assuming you will know them. Codes 20, 21, 37, 38, 40, 41 and 42. And they relate to monitoring information from 2008 to 2012 based on quarterly snapshots. If I take one in particular, code 38, that's where a patient doesn't attend, whether it's for an inpatient case or an outpatient case, you record those numbers separately, and that's very helpful. My first question, convener, is that information recorded as part of the overall social unavailability stats that have been the subject of much discussion over the past few months?
Can I, first of all, and I'll pass to John to answer in these specific codes, but can I, first of all, say, obviously, I don't accept the point that Jackie Bailey makes, because the key thing is the number of qualified nurses is actually in the increase. But we'll park that for the purposes of this discussion, because this is about waiting times, and I would have thought there would be a welcome on the increased numbers published this morning. Can I say there's a number of these codes which are no longer used? Well, take number 20, for example, code 20, which was one that was particularly the subject of some attention. And that code is no longer used for fairly obvious reasons, because basically it was allowing people to say that they're still unavailable but wanted effectively to stay on the list, when medically the decision really was that they're not appropriate to stay on the list. So some of these codes obviously are no longer relevant, but in the detail of 38, I'll ask John to reply.
If I can understand your question correctly, it's do we record CNAs, which is can't attend, DNAs didn't attend, separately from social unavailability? And the answer to that is that we publish all of those statistics separately in the ISD website. So you can see the number that are CNAs, you can see the number that are DNAs, and you can see the level of social unavailability.
Okay, so they're published separately?
You can see them separately in the ISD website as separate statistics.
Let me be absolutely clear, because I think this is an important point. We've been talking about, whether you call it a scandal or not, the social unavailability figures and how those codes are used. Okay, what I'm trying to establish is if it was a code 38, a patient not attending, is that recorded as part of the statistics we've been looking at, or is that recorded separately?
I will certainly write to the committee and clarify that to you, but it's published separately. You can clearly see the number of patients who are being recorded as cannot attend. You can clearly see the numbers that are recorded as being socially unavailable, and you can see the numbers that don't attend.
It genuinely is a very simple question. Yeah. Is it within the figures that were quoted to us as social unavailability, or are they separate? In which case, there are thousands of people who haven't even been recorded under the social unavailability statistics. They've been recorded separately.
Social unavailability is where you have a contact with the patient, okay? That record is now where a patient is advised that they cannot attend, okay, or that they wish to change their appointment. If there's a DNA did not attend, then it's quite clear that there's been no contact with the patient. The appointment has been made, and the patient simply has not turned up. That's completely separate from social unavailability. Okay.
That's very helpful. That's what I was driving at. So there are potentially thousands more people who aren't counted within those set of statistics because they're detailed as a code 38, they didn't attend.
I'm not quite sure I agree with your interpretation, but as I said, I will write about the operation of code 38 if you think that's helpful.
I think it would be, and I wonder whether you could explain just now, I mean, if you look at NHS Greater Glasgow and Clyde, which has been the subject of much discussion this morning, outpatient non-availability was 2,574 in June 2012. These are figures you supplied, but I'm quoting them so you understand, because you don't have it in front of you. They dropped to 548 in December 2012. For inpatient and day case treatment, it was at 382 in June 2012. It's now 11 in December 2012. Are the good people of Glasgow just getting much more organised and much more punctual, or what else is going on?
I suspect that you may be looking at the residue of the patients still recorded under new ways. Yep. Remember, of course, we've introduced a new system. So if you take a look at the operation of the new system across Scotland, you will find that the numbers of patients recorded as patient advised unavailability at the start of that was 0. Yep. Now, with the latest statistics published, you'll find today that the number recorded as patient advised unavailability is just around about 9,000. So I think what you're doing is you need to be careful not to confuse old data sets with the introduction of new data sets. But I'm very happy to write all of that down and explain how these statistics interrelate to each other.
I think that's very helpful, particularly how the statistics relate to going back over the old data set, how these were recorded and whether they were recorded in addition to social unavailability, because actually it could mean that thousands more people were parked on a different kind of waiting list than we've already uncovered. But again, that's a matter of my interpretation.
Saying to the convener earlier when he raised the issue about Glasgow, I think we should be careful not to compare apples with oranges.
Genuinely puzzling though in terms of changing. Does that mean that that gap in the numbers, does that mean that those people have been treated or just on other lists? Genuinely, just for clarification, we have had a big shift of numbers here, explained away with a new system, and being very mindful of, we're not the expert. Does that mean that those people, that drop in numbers, have those people been treated in the system, or are they just on other lists?
I think the best way to deal with this, convener, is we will take the specific points that have been raised and we'll give you a very detailed response, because obviously we don't have the numbers you're referring to that are in front of you, and I want to be absolutely sure so that something doesn't go in the record and then we're accused of misleading the committee. So
No, that's never happened before now, Cabinet Secretary.
That's why we're so cautious. That's why it doesn't happen.
That would be a first. But Mr Conahan seemed to have the figures and was giving us some detail there about how it would shift and some possible scenarios. But are they treated? I mean, I thought, are they on other lists?
If I had the figures in front of me, I might be able to give you, let's say, more of a detail, but I do not have the figures. I'm answering Ms Bailey here in general terms that you should not confuse two data sets. One which refers to an older system where you will naturally see patients dropping off that older list, and one where we start to populate a new system, which is patient-advised unavailability, where you will begin to see a rise. Both of these will naturally fade in and fade out of the statistics.
Look forward to the figures, obviously, and that would inform all of the committee, but why are we not, come back to that earlier question, if that is what's happening in Glasgow, then why are we not seeing that trend? It's just this issue about, if we see a variation, surely now, given our experience, if we see a variation, a red flag goes up. Now, we've got a variation here from other health boards that are not showing, like, there's an 80% drop or something in Glasgow in terms of their failure to attend, disappeared. Boom. But that hasn't been reflected in some of the other health boards. Why is that?
Cabinet Secretary earlier made reference to the fact that Glasgow was coming from, I think, 11 systems down to a single system. And some boards have had, for example, track care in operation for a number of years. So as boards move towards the implementation of the recommendations for better recording and better systems, as outlined in the Audit Scotland report, they will naturally have to move away from the older systems and start to populate newer ones. So that's one reason why you will find, for example, some different trends emerging as that relatively enormous task unfolds over the course of the next few months.
Maybe we'll just wait. I'm pleased that you attempted to give some explanation for those variations, despite seeing the figures. So I'll wait, and when we get the figures to the committee, you maybe give us a proper explanation about the variation of the different health boards. That would be helpful. Is there any other questions? Jackie Bailey.
Thank you. There was criticism that I think was touched on earlier about the level of monitoring that was undertaken by the Scottish Government and ISD alongside health boards. Did you not have monthly meetings with chairs and chief executives and with ISD previously, or is this something new? And in fact, what have you done in terms of the kind of relationships and governance structures that's different to what happened previously?
My understanding is, in fact, I'm sure that my predecessor, like me, held monthly meetings with the chairs, and Derek holds monthly meetings with the chief executives, and all performance issues are discussed.
my concern is I think both Audit Scotland and then the Public Audit Committee reflected on the fact that, you know, at some points communications just were not helpful in identifying this as a problem. So I'm very keen to understand that, you know, the Scottish Government have learnt a lesson from this alongside health boards and actually have a more robust approach in place, which is what you described earlier, but I'm not hearing the difference. So I come back to what difference has there been in your scrutiny and governance and communication arrangements that give us confidence moving forward?
I'll bring Derek in, but just kind of say there's a number of differences. First of all, we're not operating in Glasgow, for example, with 11 systems, and we're not going to be operating with 3. We're going to be operating with 1. And track care is going to be introduced, or a version of it introduced through every board area. So it means that the information between boards can be much more directly comparable. Secondly, we've got rid of social unavailability and all the questions round about that and replaced it with patient non-availability or unavailability and with a new set of rules. Thirdly, we've implemented a lot of the recommendations from the Auditor General to tighten up in certain areas. So all of these things have been done, and we are also going to carry out, as I say, a review ourselves to make sure that enough is being done in terms of the robust monitoring, the collection of the data, the analysis of the data, the interpretation of the data, the consistency of the data, the application of the rules, make sure ourselves that this is all being done throughout every board by the end of this year.
I mean, the other thing we are doing in those monthly meetings is we'll share all the outputs from all of the internal audit reports with all of the boards. So we won't just work with each of the boards individually. We'll share with all of the boards all of the output from all of the internal audit reports, so that there might be learning from a neighbouring board. And that, I think, just kind of reinforces a trend which we've been applying both in the Chief Executive's session and as the Cabinet Secretary meets the Chair, and that is just showing everybody else's data.
I think you'll forgive me if I'm pursuing this point because we need to have confidence in the system moving forward. But, you know, you've said in the Cabinet Secretary, I believe, has said in debates, you know, that the data is published. There's no hidden waiting list. It's all out there. You've talked about data coming out of your ears. The data was all there before. Nobody spotted there was a problem. And clearly there was because you've changed the system. How can I have confidence that you will spot the problem now?
So I think it's important, though, you and I have had this exchange before, but I think it is important to be clear about what the nature of the problem that Audit Scotland had been identifying. And it wasn't about the level of social unavailability. It was about the nature of that social unavailability and the absence of us having systems that would help us to better understand why it was that people were being made socially unavailable. That's the improvement that the Cabinet Secretary identified will come with, firstly, patient-advised unavailability, where you've got the exchange of letters with the patient, much stronger coding, much better IT systems.
With respect, part of the problem, clearly identified by Audit Scotland, was in the governance arrangements and the communication between ISD, the government and health boards. I've heard nothing today that actually gives me confidence that that oversight, whatever system you change and put in place, that oversight that I expect from government is actually being delivered, because you've not described any change other than to the system on the ground. And I am genuinely concerned about that.
I don't think you've picked up then what I've said earlier, Jackie, and that is that there is now a monthly meeting which involves ISD, in the monthly meeting to go through all of these statistics, and there's a level of concentration that's dedicated to this particular issue. That didn't happen before, right? And that involves every key player. I mean, clearly these are addressed at Derek's Management Board meeting, at the Chair's meeting, Chief Executive's meeting and all the rest of it. But to make sure we get this right, we have a dedicated monthly meeting involving ISD in these statistics to make sure that that's going right.
That never happened before.
Not as such, I don't think, did it?
And John would be better able to comment than me.
We never had a meeting of that nature with ISD. We had many meetings with ISD on systems development, on statistics, but in terms of looking at unusual patterns, in terms of looking at, let's say, a response from a board where ISD was not really quite satisfied with it, then that's an added security in here. I think it's also worthwhile just considering the Audit Scotland recommendations. We had a relatively positive, in fact, one of the more positive Audit Scotland reports carried out in 2010 to this very area, where Audit Scotland recorded that the NHS had done well to implement the new wage system. Now, it was never a recommendation before that 2012 audit report by Audit Scotland, published at the turn of this year, that we recorded the reasons for unavailability. That is new, and that is, I think, basically at the heart of what has changed in this system.
I should point out, of course, all the data was available and none of the opposition parties picked it up either.
Convener, could I correct the record, because factual accuracy is important. My colleague Richard Simpson was asking parliamentary questions. We raised this in debate. It is a shame that the government, with all its resources, failed where we succeeded in highlighting this problem. Can I have one final question, Convener? Thank you very much. It's about social unavailability codes more generally, and I think everybody struggles to explain why in June 2008 it was 11% of inpatients were socially unavailable, rising, I think, quite rapidly in June 2011 to 31%, before in September 2012 it drops down to 15%. No coincidence that it was after NHS Lothian was exposed. You have said on radio in the chamber that this was down to IT problems. You've repeated it today. None of the Health Board Chief Executives that came before the Public Audit Committee agreed that that was a problem. Mr. Feely, who's just passed you a note, didn't either jump to your defence at the Public Audit Committee. There was no computer system in any health board in Scotland being changed at the point there was the dramatic drop. So do you accept this isn't an IT problem?
No, what I'm saying to you is, and it refers to what the point was made earlier, is that the IT systems, as said by the Auditor General, weren't robust enough to pick up the problem. That's what I was saying. I wasn't saying anything other than that, and that's why the problem wasn't picked up. Now, what happened after the NHS Lothian scandal was revealed was that every other board then double-checked their systems, and it's at that point they realised there were things not as robust, and sometimes their IT system, sometimes in terms of just the application of policy, double counting and various other things. So it varied from board to board. So I stick by what I said.
I think he's the only person in Scotland saying it's an IT system.
No, I don't think I am. I think if you look at the Auditor General's report, she's saying as well.
Have conversations across the table with people, the committee members either. I just say that for today and for future reference. That's not the way we're going to conduct this committee. Bob Doris.
Thank you very much, Convener. I thank Jackie Bailey for drawing the committee's attention to the need for accuracy. So having sat on the Public Audit Committee as well, can I draw Jackie Bailey and this committee to one of the recommendations which said from the Public Audit Committee, the IT systems did not allow sufficient data to be recorded in order to establish whether the codes were being applied appropriately. The Public Audit Committee therefore recommends that the Scottish Government should set out the key audit data that NHS board systems must be able to record. That's a recommendation from the Public Audit Committee, but the Public Audit Committee believed the IT systems was a reason why we couldn't audit this properly. The Public Audit Committee also found no evidence of the inappropriate use of unavailability codes out with Lothian either, and I would suggest to Ms Bailey that a degree of accuracy from everyone is important when discussing this situation in a balanced manner. Ms Bailey also mentioned ISD, which is something I do actually want to ask a question on. I did seek more clarification in my first question, Cabinet Secretary, so maybe ask again, given the 10 news points perhaps Ms Bailey sought to make in relation to ISD. I should say first of all that ISD quite clearly told the committee that there was, and it's not a direct quote, I have to say, I don't have it in front of me, that there was nothing unusual or irregular in the increase of unavailability codes throughout the year. So that wasn't a situation that they would have, that they didn't, it's not that they didn't identify it, it's that it didn't cause any concerns, and they would therefore have expected unavailability codes to fall thereafter. However, the Public Audit Committee did also recommend the data should also be presented to ISD Scotland in order to help identify where capacity pressures are occurring alongside an increase in the use of availability codes. Emerging trends from these reports can then be discussed at meetings between the Chief Executives and between boards and the Scottish Government. So the question is a long context but very important. ISD does collect such a huge amount of data. They did say they did pick up on this trend, but they didn't find it of concern. Is there a role for ISD to be more proactive with data in general, where they do raise concerns to government and health boards, not necessarily about waiting times, but just in general, because I think that's something that perhaps the Public Audit Committee picked up on?
I'm encouraging ISD and indeed everybody to be, as proactive as they possibly can be. I mean, ISD obviously has a fantastic amount of very able statisticians, and they're able to keep us very well informed. As John said, over the years they have highlighted a whole range of issues that were of concern to them. They obviously didn't see this as an issue of concern at the time. As I've said, we've now got ISD more involved in our own monthly review of where we are with these reforms and the statistics. So I would encourage ISD and indeed everybody to take a very proactive approach to statistical analysis.
Okay, thank you.
Richard Lyle.
Yes, firstly, can I apologise to you, Convener, for the comments I made. But Miss Bailey, in her comments, and for the sake of accuracy, while looking at me, suggested that I called this a scandal. If she would wish to check the record, she will note that I said that other people called it a scandal. I said I didn't suggest that, and as I say, I apologise for my comments, but I don't take kindly to people suggesting that I said one thing when in fact I said something else.
If I clear this up now, if you look at the record, you'll see that I said whether or not you call this a scandal, and you clearly didn't. So I hope when you reflect on the record, you'll see that I wasn't casting aspersions towards you at all.
On that happy note, is there any other questions? Can I thank the Minister and his colleagues for being with us for this long time this morning, and apologise to our witnesses in the next session who have waited patiently to come before us. Thank you all very much. And suspend at this point. everyone, as we move now to agenda item number 3, community transport, which is to take evidence on that subject and feed into the Infrastructure and Capital Investment Committee's inquiry on that subject. And obviously, you know, this committee has got particular access to health and social care, and indeed, where many of us who constituency have come across these issues on a regular basis. So we have you know, a roundtable set up, which is supposedly to do more listening than talking. We'll see if we can meet that challenge as politicians. In the interest of time, I think what we will do is just we'll maybe introduce ourselves or whatever as we ask a question, and it'll save us, you know, a wee bit of time, because I'm conscious that we have run on quite a bit here. I don't know whether I'll just go ahead and just kick us off. And in general, we had a briefing this morning from Audit Scotland, who as you will be aware, did some work in this some time ago now, for transport for health and social care. And you know, they made a number of recommendations and highlighted issues and main findings about working together, you know, some key issues there, integrated transport strategies, all of that, with people as focus. Does anyone want to address some of the findings or the work of Audit Scotland? Would that kick us off?
Yeah.
Who then?
Would you like me to
Heather, thank you very much. That was very helpful.
Thanks. Thanks. I was part of the advisory group on the Audit Scotland report, so that's probably quite helpful. Good. And since the publication of the report, which I'll not recap in any great detail, I'm sure you've all seen that, there has been some work ongoing right across Scotland in partnership to look at how we can take forward those recommendations. From my perspective, from Scottish Ambulance Service, we're very keen to see how we can work towards the recommendations from the Audit Scotland report. And I've also been contributing with other colleagues to a short life working group about how we might take that forward. And I think we're just imminently waiting the publication of that report and those recommendations. However, we've been trying to be a bit more proactive in terms of taking forward some pilot work, and we've been working in partnership with the regional transport partnerships, the health boards and the councils right across Scotland, but in particular in 3 areas. We have a integrated transport pilot about to go live in Lochaber in July. We have a pilot programme up and running, which is developing as we speak, in Elgin, which is for the North Aberdeenshire and Moray area, which is about the partners coming together to actually bring together those resources in those areas for those communities, and to see how we can provide a much more integrated solution for patients needing to access their healthcare appointments. And we're just in the process of scoping out some work with SPT and Greater Glasgow in the Clyde area. So we've actually been progressing the recommendations and looking at what resources sit within communities, how we use the resources that sit within the Scottish Ambulance Service particularly, and how we can actually collaborate and work in partnership to secure, if you like, much better, easier access for patients to their healthcare appointments. And I think that's quite challenging. The landscape across Scotland in terms of the geography, the way that health boards are configured, the relationships that exist within those boards and councils, makes that quite a challenging piece of work. But I think we're making good progress.
Yep. I think we heard this morning, just before I throw it open, we heard that, you know, you're dealing with different groups of people in the ambulance service, and of course you're more organised to do that. I think we heard this morning, and you got, you know, I think your organisation got a bit of a tick this morning, but what you've just described, is that representative across the country in terms of the others that are here? Do they see that? Do they see that same level of progress? Do we see those strategic partnerships coming together? Do we see need being met for the groups that communities? Yes, Tom. Yeah. Robson.
Thank you for inviting me across this morning. I'm Tom Robson. I'm the representative for the British Red Cross, and I'm the Senior Services Manager for East Scotland, which covers Perth, Tayside, Forth Valley, Fife, Lothian and Borders. So I'm not talking for the whole of Scotland, but I know what's going on in the whole of Scotland. We work in partnership with loads of organisations throughout the whole of Scotland. We work in partnership with the Scottish Ambulance Service, delivering programmes. We work with the National Health Services throughout the whole of Scotland, mainly from our home from hospital schemes and our discharge schemes from the discharge boards as well. We've got discharges from St John's Hospital in Livingston, the Borders General Hospital. There's in the west of Scotland we do discharges as well, and we work in partnership with different voluntary organisations. We work with the Macmillan Cancer Research. We run a transport initiative from the Scottish borders to the Western General, taking patients for their chemotherapy. I think I've covered about most of it. So we're willing to work in partnership with them, and that's the way forward, is to work in partnership.
Yep. Callum?
Yes, my organisation is Voluntary Action Scotland, which is the network body for the third sector interfaces in Scotland, which the committee members will probably know better as centres for voluntary service, volunteer centres and so on. And what we find is that there's, in some ways, in a good way, a patchwork of different solutions that meet the local need going on across the country. But one of the downsides of that, of course, is highly varied provision across the country. So Heather mentioned the Voluntary Action Lochaber example, which I think might provide a potential model that we could look at elsewhere, whereby because of Voluntary Action Lochaber's connectedness, its connectedness with the community groups, its relationship to community planning partners and so on, is in a good position to broker the relationships locally to actually develop and then actually run a community transport service where perhaps British Red Cross and others are not present. And there's other examples where the TSI is trying to develop that relationship. In Aberdeen, there's a model that's being developed at the moment with support from the business school and other partners locally. And I think that might offer some kind of a potential for a way forward, because the feeling from the third sector interfaces is that we've got this backcloth of increasing demand in terms of an ageing population, but we've also got a bit of an opportunity, because if we can understand community transport as being part of the reshaping care agenda at the same time, then we can see how improvements to accessibility and mobility can actually, if you like, form part of a preventative approach. So I think this is an area that's very important for Voluntary Action Scotland.
Patterson, followed by Anne Harness.
Okay, hi, Margaret Patterson. I'm head of operations for Royal Voluntary Service, which was, until very recently, WRVS. So I am able to give sort of a cross-Scotland picture, and certainly in our organisation, community transport underpins absolutely everything we do in terms of the services we deliver for older people. What I can say is that, yes, there is a rising need across the country, and there are areas where partnership working is developing and is showing signs of improving, but there are other areas where it is simply not happening. And I can give examples in two areas where I've actually had to pool, where I've had funding for transport services, and I've had to pool those services because I haven't been able to get engaged in local partnership working, and therefore have not been able to establish the service. And one of those areas was Elgin, which is quite a disappointing situation to be in.
Anne Harness.
Thank you. My name's Anne Harkness. I'm the Director of Emergency Care and Medicine within NHS Greater Glasgow and Clyde, and I lead for ambulance services within our health board. Obviously, the Scottish Ambulance Service is the main provider of transport to and from hospital, but we do work closely with the Strathclyde Partnership for Transport in terms of improving access and improving services for people in our health board area. We've got a number of examples where we work with community transport in things like our evening visitor service, and where we run services in the community, we engage with community transport providers to help us, particularly frail older people, getting to community exercise classes, for example, and as Tom mentioned, we work with Red Cross in terms of an A&E take-home service. So I do think that there is a huge opportunity here for working more jointly, but again, I think it's probably at a regional basis, while in setting a strategic direction, while allowing that local variation that Callum mentioned, because community transport providers are so diverse. The other issue, I think, is about integration and the relationship with social care. As we move much more to an integrated health and social care service, particularly for older people, I think there's a huge opportunity for us to work closely with our social care partners who in the main fund community transport and also are big providers of transport in the way that the ambulance service is for the NHS. And that's another area where I think regional collaboration would be hugely helpful. And within our area, we're just about to do a piece of work actually in your own area, convener, with the CHCP, looking at what opportunities there might be to look at health and social care transport, perhaps for non-patient related transport, but potentially also to look at some of the social care transport to help us with patient transport arrangements.
I'm glad to see we're making some progress locally in it, but there's lots of opportunities. I've been banging on about that for quite a time. Peter?
Excellent, thank you. I'm also from the recently renamed Royal Voluntary Service. I'd like to reiterate our thanks for inviting us here today. I was giving evidence to the Infrastructure and Capital Investment Committee last month on the issue of community transport, and I think the point that was well taken there was that there's a need for a strategic focus on this in health and social care integration. We think that the debate on health and social care integration up until now, although it's been interesting, has been very focused on structures, and we think that looking at services is a useful way to understand what the benefits of health and social care integration will be. And one of the key services that we don't think has had a great deal of consideration, and that is community transport. And at risk of talking further about appointments this morning, it's pretty clear that community transport is one of the best ways to ensure that appointments aren't missed. That's a good way to prevent the incurring of unnecessary costs, and it's something that we're very keen to be involved in. But we feel that this needs a more strategic focus, and it needs to be built into the systems that are being created for health and social care integration.
Who should pay? I mean, the other issue I think it came up with the audit committee, and I'm happy to try and keep this going, but I'm looking for help from others, was a question of who pays for this. This is, it goes back to my own experience, particularly at a time of change in my community about services going out and the impact of that. Nobody had considered that. There was a reluctance from the Health Board to take on that commitment of people, transport, getting from Greenock to Paisley to visit, to support, you know, and attend appointments and issues like that. So who should be, who pays for this? Callum.
I mean, at the moment, this is the thing: is it's going to be a patchwork quilt of arrangements and what can be developed locally. And I think one of the challenges is that that you'll hear talk on other issues relating to the third sector is 1 year funding, because in order to develop and broker a decent quality of service that has something more of a strategic approach and builds relationships, then if it is only 1 year funding, when you're talking about assets that relate to community transport, that's an extremely difficult thing to manage. So with local authorities and going in that direction, as well as Scottish Government, that provides a significant challenge. But one of the benefits of involving the third sector in community transport, of course, is there is a good supply side in terms of willing volunteers, cars, other forms of transport, you know, vehicles available within the third sector. And it's about, I think, kind of, if you like, finding small amounts of support to be able to coordinate and focus that better in a longer term way. So you're actually able to then, you know, leverage in those resources that exist in the community at present, but in a better and more coordinated way.
Anyone else?
I think the reality is is that the ambulance service and the NHS fund transport on the grounds for people who need it on medical and mobility grounds, and people who need transport on social or isolation grounds are in the main funded by local authorities. So that is one of the challenges about an integrated model, is how you adopt a slightly different approach to funding. Although, as Heather will describe, I'm sure there are lots of pilots where we can do that flexibly, but they tend to be they're kind of pilots on quite small scale at the moment. And certainly our board has used its own NHS funding on occasion to fund community transport, where, for example, we have made a service change and we recognise that will impact on people's ability to get to hospital. The Vale of Leven would be one of those examples where we both funded additional ambulance services and we work with transport partners to ensure that public transport is available, and we put in additional community transport. So when we make a service change, we have a community engagement and transport manager who works with us to make sure we take into consideration and allow for the impact that might have on people's ability to travel.
I mean, the new clinical strategies, for instance, will the new clinical strategy from Glasgow Clyde include a transport strategy about how you manage that change? Because it didn't in the past.
Any strategic change any NHS organisation is undertaking has to include a transport needs assessment and impact assessment, and that's required by the government when we would do that. So absolutely, we would have to do that.
So if your budget went up or down in Glasgow in terms of what's available for transport over the piece?
The budget is held by the ambulance service.
So it's not direct to your budget access to that. Much does Glasgow Clyde pay for taxis to take people from Inverclyde to Dumbarton or all over the place, or take files and...
I don't have that information with me. I can certainly get that if that would be useful.
Yep, thanks. Heather, did you want back in?
Yeah, it was just to say that Anne talked about volunteer car services and things. I just think just to recognise that the Scottish Ambulance Service is primarily funded to take those patients who have a clinical and medical need for ambulance care and transport, but not to lose sight of the fact that we still employ 200 volunteer car drivers, because we recognise the difficulties that exist across Scotland for those patients who are in remote communities and those people who have real transport needs who need to get to hospital. And we primarily try and focus that volunteer car service on those ambulant patients who do not need care or assistance but actually have a social and geographical need for transport. Now, that has diminished over the last few years, there's no doubt about that, in terms of the numbers of patients who use that service and the number of journeys that service provides. And primarily that has resulted from some of the changes in the HMRC guidelines around taxation and things, where volunteers will drop out at a certain limit where their payment reduces as a result of some of those guidelines. And also to say that, you know, that volunteer car service for us, we need to be very clear around the governance around that, because we need to be sure that we select the right patients for that kind of service, because it is, as it says, a volunteer car service, and we need to be careful that we don't select patients for that service that probably do need some care and assistance en route to hospital. So that was the reason for us working quite extensively with 14 health boards and the clinicians in those boards to develop what some people will have heard previously about eligibility criteria, which is not new, it's been around for a long time. It was based on guidance in the early 2000s, I think it was about 2007, the latest guidance. But what we wanted to be clear about from a clinical perspective was that we truly understood the clinical needs of those patients and the care requirements that they might have, and we selected the right mode of transport for those patients. And I think that's quite important to stress that, because in lots of debates around those integrated solutions, people lose sight of the fact that that we're not just providing a transport solution. We have lots of patients who have multiple comorbidities, long-term conditions, often transported on oxygen therapy or stretcher, or needing some complex assistance around moving and handling. So I think I'd just like to kind of reiterate that.
Thanks. Any other? Yes, Peter.
I just wanted to take you up on the point about who pays. I mean, I think it's been quite clear over the past 4 or 5 years that by preventing need, we can save money. And I think getting patients to their appointments is a good way to save money, and the costs involved in community transport are actually relatively small when compared to the costs of missed appointments. And looking at the global cost of missed appointments as a way of funding that may be a way in which to release some funding for more community transport. And similarly, you point to the use of taxis. I mean, quite often we think that we could provide services that replace existing taxi services. And they don't just replace the point-to-point journey, they also add additionality, in that we'll do a safe, warm and well check with the individual in their home. We'll maybe be able to signpost them on to other services. So it's a way of adding value to a journey that would almost certainly be cheaper than it already is in a taxi.
We're unsure, Peter, whether any of that work has been carried out in terms of the impact on good quality transport being available, and whether that does create a saving or reduces exclusion, say, for admissions. And so is anyone aware of any work that's been done in that area?
In terms of the Lochaber pilot, I think what that has flagged up is that there is actually some lack of information. I heard you talk in the previous session about data coming out your ears. Actually, when you look at community transport networks and providers, there is a real lack of accurate data around what resources are in a community, how they're used, what volumes of journeys that they do undertake. And to be fair, until a couple of years ago in the ambulance service, our data wasn't particularly robust either. We've now invested about £2 million in mobile technology so that we can track vehicles, and every journey has, is in the same way that our A&E service functions, has a patient record attached to that. So I think the data gathering is getting better, and I think that has been really beneficial in the Lochaber area, where people were quite happy to come and share their data, and actually to improve the data that they collected around what resources sat in the community, how they were utilised or not, as the case may be, and what the real potential was to build in that community a much more integrated solution. And I think that's probably where we would want to go, particularly in those areas where there's high levels of deprivation and there's a social and geographical challenge around commuting back to hospital. I think alongside that, what I'd also like to say is what we would like to do is not just work around transport solutions, but on the emergency side, we've really developed quite advanced thinking around how we can care for people in their community rather than transport them to hospital. And I think if you look at some of the work on the outpatient programmes, we can sometimes take a patient 100 miles for a 10-minute consultation. Mm-hmm. And what we'd like to encourage is work with the boards around how we can actually take them to the local community health centre and have that consultation done by telehealth or telecare, because actually that would be a far more effective way for some of these patient groups, and not all I accept, but sometimes that's just a conversation about a follow-up procedure and it's relatively simple, but we're still moving patients around a lot for very short and non-emergency consultations. So that's part of our work programme as well, is to work with the health boards around how we encourage that. And for us, that would put much more resource back into the local community and would certainly help us moving forward with integrated social and healthcare agenda, which is about providing care in the community. Because if those resources are not travelling long distances with small numbers of patients, then they would be available to move people around in their communities. So,
an interesting point. Yes, Anne.
We certainly, the Strathclyde Partnership Network has the West of Scotland Community Transport Network as part of it, and that would bring all the community transport providers in the West of Scotland together, and that allows us to do that better coordination of resources. And we did a 2-day snapshot of every journey that was made in NHS Greater Glasgow and Clyde by taxi, by our own NHS vans, not by the ambulance service, and we've shared that with the SPT, and we're starting that work about looking at the synergies, exactly to pick up your point about where are the synergies and where could you use alternative, more cost-effective solutions. Within the NHS and our board, certainly we do use taxis for patient journeys on occasion, but it will be an exceptional and in an emergency situation. We won't use them routinely on a planned basis, so it would be on a one-off basis that is really a particular individual circumstance. So it's not, we don't use them routinely for transfer to and from hospital.
It might be interesting if it's available for the committee to have that work.
I don't have the detail, but I can check how,
Yes,
how
I
it's
appreciate
available.
that, yeah. Is there any other witnesses on the panel, just before I go to another? Yes, Tom?
Just say that the British Red Cross main challenge is funding, is the main thing. But what I'd like to say is that to produce a quality service that the ambulance service does, that the British Red Cross, all their vehicles are CQC compliant. There's a range of vehicles that we have. There's all-wheel drive vehicles, wheelchair accessible vehicles, the volunteer vehicles, they're all checked. The driver licenses are checked. They're all done, their first aid training, moving and handling training. And the service that they provide is absolutely excellent for a donation-based, what the person who asked for the service. And unfortunately, it's unsustainable for us to keep doing it on a donation-based service, because all that costs money to produce the vehicles and all the training that goes with it.
Bob Doris.
Thanks, Convener. It's always actually better when witnesses are just having that conversation with each other rather than the politicians because they're asking questions. But I do have a kind of a very specific one. I was kind of inspired a little bit by Peter McCall talking about how there's money in the system you can take out. So, for example, the cost of missed appointments, whether it's GP appointments or community health appointments through the NHS, is far greater than, say, the cost of a modest increase in investment in community transport. We heard this morning from the Cabinet Secretary in relation to the various pressures on the NHS for inpatients and the knock-on effects on that. So, for example, one of the reasons for delayed discharge may be consultants not reviewing patients until an afternoon rotation rather than the morning, the slowness of getting medication for patients on discharge. Of course, it could be the lack of support at home or in a homely setting, but it could also be the lack of transport to take a patient who's otherwise fit to go home with the relevant support. So I'm just wondering if any of the witnesses can give me an example of whether they think that, or tell me first of all whether they think that is a problem particularly, if so how large is it, but more importantly are there any initiatives going on within any of the health boards in terms of change fund monies or whatever to work with the Scottish Ambulance Service and community transport partners to ease that, because the knock-on effects for delayed discharge and things like A&E waiting times and everything else are significant, and that would be another way of taking the cost back out of the system and reinvesting it in community transport.
Hand over to Margaret.
Margaret, yes.
In terms of examples, yes, there are examples dotted around the country where well, certainly there are voluntary services involved in providing transport on discharge. So an example would be here in Edinburgh, where we work, a scheme where the discharge is organised within the hospital and then the volunteer drivers are available throughout the day according to the need to take people home. And that often links, as you say, with all the other reasons. We would often then have someone available so that when the person is discharged home, they're getting the support necessary. So those schemes do exist. That one is funded via the NHS. We do have change fund schemes as well, where we're working to ensure that people are getting to appointments. So we have an interesting one in East Lothian, which is actually GP referral, which is a scheme where the GPs will refer where they know that they have someone who requires transport to get to either GP appointments or hospital or clinic appointments. And that one is also quite an effective way of ensuring that the appointments are not missed. So then those are just two examples. There are many others.
Yeah.
We've also been working in Edinburgh, in Lothian, particularly with the Royal Infirmary in Edinburgh, and actually it's a very successful programme of work. We embarked on a 5-year improvement programme for our patient transport service, and one of our primary aims is actually to support health boards with their acute discharges to keep the flow moving in hospital, and we see that, again, for those patients who need ambulance assistance as quite high on our priority list. Now, Lothian do use other services for those patients who need a transport solution and are ambulant again, but need some assistance to get home, some transport assistance to get home. However, they have been using private ambulances because of the pressure on demand, and over the last 6 months, Lothian have developed an internal transport hub which we work in partnership with. We jointly staff a health board liaison officer who can help us bridge the communication gap that often exists in terms of some of the immediate requests. And I think you're right. I think decision making within the hospitals sometimes gets under pressure, and the demand for discharges same day has increased over the last few months. So we're really focused on trying to assist with that issue so that we can help our colleagues keep moving. And I wouldn't like to mislead the committee by giving figures because I don't have the up-to-date figures, but my understanding is we've helped them to reduce significantly the cost of private ambulances by increasing our utilisation and productivity within those resources that we've got around the Royal Infirmary in Edinburgh. That's the kind of work that we want to spread over the next year or so with some of our other colleagues, and particularly I think Glasgow have some significant challenges as well. So it's a kind of incremental programme of work, but I think as well as working with the voluntary agencies around the patients that they do provide those services for, I think we're really, really keen to make sure that we can increase the offer that we make around hospital discharges from an ambulance service perspective.
Okay, Tom.
Bob, another example of getting patients to the hospital is in Fife, the people with blood-borne viruses, we escort them across to the Western General for their treatment. Now, the type of patient that it is would mean that if the transport wasn't there for them to go to that hospital on that date, they just wouldn't have turned up.
Any other responses to Bob's question? Yes, Anne.
We similarly have projects. I mean, as part of our routine discharge arrangements, we would have services from the ambulance service in the evening, picking up your point that many people now go home in the early evening following the kind of change in the pattern of admission to hospital, in that many people are now admitted later in the day. So we would routinely have ambulances available to take people home from hospital, and we are working with the Red Cross as one of our Change Fund projects within Glasgow, in the south of Glasgow. We've got the Red Cross who help us take patients home from A&E who don't need to be admitted, and then they provide that care and follow-up, as I think that the colleagues from RVS were saying. So they make sure that people have got something to eat and the heating's on and their home service are in. So I think local Change Fund partnerships are looking at community transport with a kind of care element on it as much wider than just providing a vehicle. But there are a range of options about how you do that, and as I think, as we've heard, there are a range of providers who can provide that service.
Yes, Paul?
Yeah. Just very briefly, I mean, all of it sounds really quite reassuring. And I'm going to suggest a structure, but flexibility seems to be the key word when you're working in partnership. I was just wondering whether there's examples of individual health boards or individual hospitals or individual wards identifying where one of the reasons where there's routine daily discharge is because of transport, and whether any of the partnership organisations is then asked to focus specifically or, provide greater amounts of volunteers to certain areas and deploy them to release those pressures. Because one of the things we're looking at this morning is how you can respond in real time to those pressures as they arise. So I'm just wondering how responsive it is to where the pinch points appear within the system. I know there's lots more you do in terms of getting patients to appointments, and I'm looking at one very narrow aspect of it in relation to, in hospitals where a patient's been admitted. But is there any evidence of that kind of almost real-time collecting of data and going, we need more resources here, let's talk to this partnership organisation, let's see if they can deploy their volunteers here, more top-heavy in this area as opposed to another part of the country?
Anyone wish to respond to that, Anne?
I think the short answer is probably no. I think at a local level we would do that. We would look at our own local resources, and we would look at whether we've got a particular shortage of, say, renal beds, for example, and that's a West of Scotland service. So we would look, and if we've got particular pressure on renal beds, then we'll link with the ambulance service, and we'll prioritise getting people home from the renal unit compared to getting people home from another area. I think and our responsive service in terms of the real time will tend to be with the ambulance service or potentially alternative providers. I think that we don't have that flexibility with community transport. They provide a kind of scheduled service with the exception of this Red Cross A&E service. And I suppose I would say that that service in particular was developed in response to feedback we were getting from both patients, carers and from clinicians saying that we are admitting people to hospital sometimes because we can't get them home. We don't want to use a taxi because we would be worried that that person wouldn't be safe when they get home. So that Red Cross service actually was developed on the back of feedback from clinicians, particularly in the ED, which links back to your earlier conversations about the pressure on the kind of year-round pressure and increased number of admissions and attendances.
Annette.
Yes, really around the criteria for eligibility for patient transport, particularly in some of the relatively remote areas. And I've illustrated, not really how these criteria are set, illustrated with a constituent in a very small village in Aberdeenshire who had to go to the eye department in Aberdeen on a number of occasions, was assessed as not requiring patient transport. Happy enough to drive in, he's a driver, drove in his car, but of course the treatment involved pupil dilation, which meant he was not able to drive back home. The public transport situation in that area is pretty poor. What does a person like that mean? How is that decided? Is that sort of thing decided centrally? Is it an individual health board thing? It struck me that chap was getting a particular raw deal.
Yeah. I'm not going to mislead you. We have had some challenges in terms of the new model that we've introduced in terms of our patient-focused booking system. Historically, GPs and hospital clinics booked patient transport for the patient. And we consulted quite widely with the public around a direct access patient self-booking system. And I have to say in the early days, the variation in skill from our call handlers varied in terms of using the triage tool, the assessment tool. And we have found that some patients who would absolutely, require ambulance transport perhaps fell through the net. And I think we're improving on that. I think we're seeing, we had a few months where our complaints were a bit higher than we would have liked, and we had a number of issues raised from patients around challenging that needs assessment and that eligibility criteria. So we've done a lot of training and development with the staff. They used to sit dispersed across Scotland in 30 local offices. They're now embedded within 3 regional control centres, and they are supported by clinical advisors who are either trained nurses or trained paramedics, so that they can ask for advice and they can screen patients. And we've further developed the tool so that we ask the right questions about which clinic the patient is attending. We don't obviously want to go into confidential information about a patient's condition, and the questions have become much more conversational around what that might entail. Now, there are issues when a patient might not know at the outset that they would be having treatment that would affect their return journey. But we have now embedded a request system in some areas, and that's not holistically right throughout the country, where we can flag the issues from the clinic back to the control centre to identify actually this patient should have had ambulance transport, so we can get a feedback loop both from the Crewe Road staff and from the hospital clinics. So we're trying to make sure that we cover that gap, because it is pretty important, and it's a real issue for us. Yeah.
Can I ask when that system came in? I'm talking now maybe 2-3 years ago when I was dealing with this particular person. Is it since then? And I mean, the kind of person I'm talking about probably wouldn't actually need an ambulance, need a car of some kind.
And he's probably the kind of patient that we would use the volunteer cash scheme for. Yeah, yeah. And that system was introduced in the north of Scotland in April last year. We rolled it out to the east of Scotland in October, and the west of Scotland was in the middle in June. So we created those 3 call centres.
In that loop somewhere.
Sorry?
You said north and east. Is north east somewhere within that loop?
Yeah, north east would be in the north. In the Grampian region would be in north, and the control centres in Inverness. Yeah.
Gil Passerson.
Can I make an observation, but happy to take comment on it, that the nature of community transport itself, you couldn't roll it out the same model across Scotland. The diversity, I mean, the idea that Greater Glasgow and Clyde and Highlands would operate a similar system, I think would be impossible. In fact, even in Greater Glasgow, to manage within that area, you need a whole diverse nature of the transport system or public transport system, a community transport system. So therefore, it's in the very nature of it. I think it's got to be, you know, locally focused and controlled. But keen to hear if people would like to contradict that. But my main point is that one of the pinch points for the third sector is the ability to use capital to replace vehicles. But at the same time, there's organisations and local authorities and the health service and transport, public transport systems where there's vehicles, for instance, lying there during the day, not being utilised. So I'm wondering if people around the table have thought about that, and if they're likely to engage to utilise that, so allow the third sector to use a vehicle when it's downtime for them.
Peter.
I mean, I'd accept the point about diversity. I mean, you're quite correct that there are different services provided in different ways in different places, but I think we mustn't allow that to create a situation where there's not a strategic and structured approach to encouraging the use of community transport where it's possible. And I think sometimes those two things become conflated. It's different everywhere, but that doesn't mean that it can't be provided in some places, and it doesn't mean that we shouldn't consider it in some places. And to take your second point about vehicles owned by public authorities, WRVS, or sorry, the Royal Voluntary Service, I do apologise, does use local authority vehicles in some circumstances, but that they're not necessarily very good at letting us know what they have, and they're not very good at letting us know when they have them. And I think were that to be more structured, it would encourage a lot more community transport services, and we'd be able to deliver more in more areas.
Who else have we got?
I take it that what you're really looking for when it comes to diversity is a blueprint that rather than control. That's what would maybe fit the bill with your own comments.
I think some of that is about expectations as well. You know, so if I take the Aberdeen example, partly where that work in coordination has come about now is frustration on the part of some of the third sector agencies locally that there wasn't a community transport thinking going into previously funded projects. So there's a degree here which it's kind of making the case for community transport being considered as part of, you know, reshaping care agenda, health and social care integration, as we've discussed. It's not that it has to be the same everywhere, but it should be something that is considered when you're talking about planning services locally, because all the other health issues you've been talking about today, it's an underpinning issue, community transport. And if that was kind of sold better, if you like, when in, for example, community planning circles, then we could look at how the third sector could step in and actually itself make the case for the resource sharing that would actually fill the gaps around Scotland.
For that, Aileen.
No, I just really wanted to put on the record this afternoon that, you know, there is another project that hasn't been mentioned already, and it picks off from the Audit Scotland's report where it talks about the benefits of having integrated transport units. Now, this is in terms of one part of an area that I represent myself in Dumfries and Galloway, and Dumfries and Galloway Council participated as one of the main partners in the Rural Transport Solutions Project, which is EU funded through the Northern Periphery Programme with partners from Finland, Sweden, Iceland and Shetland. Now, this project was piloted in Wigtonshire back in May 2011 and completed in December 2012, and it involved partners including Swesstrans, NHS, Dumfries and Galloway, the Scottish Ambulance Service, and I can see Heather Kenny is is nodding her head. And obviously they were working closely with the local community transport providing the Wigtonshire Community Transport to try and address issues in transport in a very vast, remote rural area like Dumfries and Galloway, and particularly for our health and social care services. And I know there's an evaluation report that was published in February, and it's probably worth the committee having a look at that report, because there are some interesting conclusions. And if you can bear with me, Convener, I think it's important to share some of these. They concluded that in providing transport through the project, the Wigtonshire Community Transport has increased its passenger and journey times, its passenger and journey numbers, as well as utilising the shared vehicles efficiently and significantly reducing vehicle downtime. Now, these resources, including vehicles and drivers, have been shared between the partner organisations to provide sustainable and flexible transport solutions. And the central coordination of vehicles has provided the ability to service different sections of the community, including ARCs, schools, community groups, youth groups and sport clubs in Wigtonshire. And the Wigtonshire Community Transport has also secured an income source through delivering the services, obviously, for the partners that I mentioned earlier. Now, I understand that it's intended that the rural transport solutions model is going to be extended across Dumfries and Galloway to include more community transport providers, bus operators and taxi firms, in addition to further involving the NHS in Dumfries and Galloway and obviously the Scottish Ambulance Service. And I understand that work is currently underway with all the local partners to develop a detailed plan for the rollout of the rural transport solutions, and some potential opportunities have been identified, including assistance with transport to attend NHS appointments, transport to rehabilitation centres and transport for out-of-hours patient releases. And obviously NHS Dumfries and Galloway has indicated that funding support is available for coordinating activities relating to the delivery of the rural transport solutions. So I was just keen to put that on the record, and if any of our witnesses this afternoon have any comments that they'd like to make.
Sorry, Elaine, I should have mentioned that. Those 3 pilots that I spoke about have emerged since the publication of the Audit Scotland report, and that work was clearly underway before that. But I think one of the other things that was quite interesting about that work, and I think has been really helpful for us, was the work that Dumfries and Galloway NHS did around zoning patients and actually improving scheduling so that we could coordinate transport solutions to healthcare much better. And I think that has been really... We've built on an awful lot of that work in terms of our thinking around how we might work with other remote and rural communities, so it was really particularly helpful.
Drew.
Thank you, Convener. This may probably fall more into the territory in this that the Infrastructure Committee will be looking at itself rather than looking to us for evidence on, but I wondered if people around the table would just comment on in terms of the people who are reliant or perceive themselves to be reliant upon community transport services, the impact of inadequate public transport has, and public transport change, and what that means for you in terms of delivering a service and doing the work that people are talking about, of bringing people together, coming up with an integrated strategy, and then somehow there's a change in the public transport setting which results in more people either contacting, whether it's the ambulance service and going through your system or any other point in the system, saying, well, suddenly I feel that I can now come into the community transport part of it, not necessarily because of a clinical need, but simply because of a lack of any other provision for them.
Any comment on that?
I mean, we haven't got any studies into the impact of community transport or public transport vis-a-vis take-up of community transport. But we are aware of the impact on some older people around the availability or how to access public transport. So there may be sufficient public transport in the area. So the bus might be running, 6 times a day, and it's perfectly adequate for them to be able to get into their nearest populated area. If they want to go into the theatre, there's a bus that will take them home. Often the problem is they can't actually access the bus. They can't get to the bus stop, or they're not able to actually use public transport. And again, then the community transport might even be getting them there and then buddying them on the actual public transport part of their journey. So it's quite a kind of complex and complicated area around that, I think, that certainly we haven't done any particular study in, but develop our services and flex our services in response to the sort of comments we get around the availability and the access of public transport.
Yes, Anne?
I think obviously that issue is primarily an issue for local authorities, and I think with the changes in public transport, that has led to, I suppose, more of a focus on community transport and either subsidising bus routes or looking at alternative solutions. And I think we have done some joint work with our local authorities where there are particular bus routes that we are aware are potentially not profit-making for the operator. And again, the Vale of Leven bus that crosses the river from the Vale of Leven in the north of Clyde to Paisley in the south of Clyde is a public transport service that we jointly subsidise, because we recognise that we need people. We provide health services in both north and south of the Clyde, and we help subsidise that. So there are some changes, and that has led to us looking at different solutions that do involve both community transport and alternative public sector solutions.
Yes, Heather.
It's not about the impact of changes in public transport, but in the Aberdeen pilot that my colleague sitting next to you referred to, and I'm sorry I've lost his name, Aberdeen.rural team at Aberdeen University have been working with a technology solution that can be available to hospital clinics and to the information centre that we talked about in Elgin, where when somebody phones up for information, it's a kind of more advanced version of Travel Line. It pulls in all of the solutions that are in that local area, and it can link journeys so that if there isn't one single solution, but there is a combination that might help people to get to their journey, they can actually identify that. They can also give them variations in their journey and actually cost that for them. So we're trying to test that out with part of the Think Centre that's in Elgin. It's not live yet. We've got a database at the minute, but in terms of real-time information, we haven't actually managed to get that functioning as yet, but it's one of our aims for the rest of, over the course of this year, is to get that embedded so that people can understand the transport, because actually people sometimes don't know what transport solutions are in their area. So by giving them a start point and an end point to their journey, we can actually help them to plan it and cost it.
I think that's an important point, just based on my casework. We've had issues in and around this. The classic example was the family that always use the grandmother, whose husband was a terminal illness at IRH at Paisley, the mother who currently wasn't employed, and the granddaughter, the daughter who currently wasn't employed, and the granddaughter who was in part-time employment, and it cost them £30 on a Saturday to visit their terminally ill grandfather in IRH at Paisley. Now, these services were reconfigured, but while it took in to affect getting that patient to Paisley or whatever, it doesn't look at any of the other issues. And I can understand, and it relates to my question, Anne, you're the only health board person here, is one of the barriers here that we don't want to get, we need to look at the transport areas as impacts, and the ambulance service and patient transport is there. But we do not want to get too involved because there may be budget implications. It's not our job to get people to and from, other than it's an emergency or they're ill. And it's the local authority's responsibility, and they're reluctant to take that on as well. Is that a barrier or a fear about claiming responsibility for this issue?
I think it just illustrates why we need to address it in partnership. I think and I think health and care, social care integration and the regional transport structures will help us do that. But I think there is no doubt we need to work much more closely and link the ambulance service into that. And I think, although it might not be our responsibility to make sure that people get their visitors, absolutely, we in our transport assessment that we do, we would absolutely take that into account. In a recent exercise I was involved in, we absolutely did surveys of all the patients, all the people who had visitors, how the visitors got to the hospital, what methods of transport they used, whether they got public transport, whether they walked, whether somebody else brought them, whether they drove, and absolutely all that information would then be presented to both both the board and the government so that we would be absolutely clear about what the implications were and what arrangements we were going to put in place to mitigate that effect. So whether that might be a community transport solution, whether that might be working with a bus provider to make sure the bus route perhaps runs later in the evening, we would have to find a solution to any issue we identified. So just because it isn't our funding responsibility doesn't mean it's not something we would take into account in our planning.
Just on the, again, it's a bit of a hobby horse of mine anyway, but in my local area, for instance, and it'll be replicated, I'm sure, we've got the out-and-out community transport, we've got the volunteers at the hospice, which takes cancer patients for treatment in Glasgow, we've got social work transport asset, we've got the ambulance service, we've got my bus, and depending where you are, there'll be the debate about that, but whether it actually takes you for a hospital appointment or whether it doesn't take you for a hospital appointment, whether you can go to the doctors with that, so there's all of that. And of course, we've got others like the Royal Voluntary Service who I've heard have intervened in that. So all of this is sustained by public money and voluntary contribution. There is software there, and has been software there in South Clyde region that is available that can put all of that asset, use all of that asset more effectively to cover all of the instances that we have talked about today. So I suppose, collectively, why hasn't it happened? Do we need, why do we need to push these people to do what they're doing more effectively? Why hasn't it happened? Nobody knows. Is there a worry from some of the voluntary providers here that they don't want sucked in to? They lost their ethos, they maybe lost their volunteers, or lost control of their charity and organisation. Is there a concern there? Yes, Callum.
I can't speak for the other third sector colleagues here, but from the point of view of the third sector interfaces in their different guises, there's no concern about that, because for many years in previous guises, they would have had, part of their job would have been to build those kind of relationships with the statutory sector, to provide the coordination where it works, and it's been a challenge in some instances for various reasons to do that job. But I'm afraid it's sometimes it just comes down to resource. Some of the, certainly from the point of view of the interfaces, although there is funding for the core work of interfaces Scotland-wide, it's in a local area, say like Lochaber, or a rural area, or even in Glasgow itself, that funding is relatively small. So there's just a limit on how much of this coordination and planning you can actually do. And I think part of my pitch here really is if we wanted to do this in a different way, there is an infrastructure there that could be better supported to provide that kind of coordinating function, then make the case, for example, to SBT to say, let's share those resources, or to the local authority or whoever it is. But it's just not, in Scotland we have this expectation of a bigger role for the third sector, but the resources aren't anywhere near realistic enough to actually achieving that. The third sector is still a relatively small feature within a lot of these things that you're talking about.
A lot of what you do is actually organising and planning these journeys. That's pretty expensive. And there is a software model there, particularly in South Clyde, that can send you. If you're an old lady who wants to go to the hospital that day to see the consultant, you're not caring if it's my bus, whether it's the social work van, or whether it's, as long as that transport's sufficient of quality and get you there. So how much does it cost to run those organisations and plan and have the clerical staff behind the scenes to plan all these, from all of these? This is just an Inverclyde.
I'm not an expert at all in community transport, and I know the evidence given to the Infrastructure Committee has described some of the barriers that providers have found in terms of working with statutory sector, and lots of technical detail about driving licences and so forth. I think there is no doubt that the next challenge for the regional transport hubs is exactly what you say, to much more robustly challenge both the NHS provided transport and the social care transport and link community transport into it. I don't know enough about whether there are technical and legal barriers to taking that forward. That would be we would need an expert, I think, to give us evidence on that.
Do you want in, Jane?
Please.
Yes.
I should declare an interest. I'm a councillor in Fife, and I'm going to talk about Fife, so I think I should do that first. This is about transport to health, this is about health and social care integration, this is about health and well-being, it's about people being able to get to the bingo, because that's important too. In Fife, colleagues might be aware that there's very little community transport, but there's lots of people being transported because the council runs it in-house for all the reasons you alluded to, convener. It's cost, it's coordination, it's the need for investment, it's the need to be able to track the spend. And I would like to draw the committee and colleagues' attention to the fact that some of the data that's collected in Fife about where people go, if they've got the choice, that's very interesting, and what it costs. And if we're talking about transport planning, it might be useful to inform our transport planning, because if you discover that people are going to the bingo a lot or going to the hospital a lot, then you can talk to Stagecoach about maybe putting some routes on. So I think we do need to work together. There's a strong need to work together, but it costs a lot of money. Fife Council spends millions of pounds every year delivering door-to-door demand-responsive transport, which is what we're talking about. So cost is an issue, and it is a barrier. But there is software. The reason I was smiling is because we have that software in Fife. It's the same software, and that's a good way to make the most of all our resources, but it involves new kind of partnerships and a lot of honesty and changing relationships. So just would throw those comments into the mix. I'm not trying to be controversial, but there are huge challenges. Today's been about health, but it's about people just getting where they need to go when they need to be there.
Is there any other? Nanette.
Just to say what Jane Baxter just said, I mean, that would tie in with what Audit Scotland said to us this morning, that they see a need for sort of central leadership and direction across Scotland to bring everything together.
One final question I'm promising the committee members. The lack of information that was alluded to in the public sector, still, you know, not a timetable in my hospital about the buses that would run in there or whatever, despite going on and on about that. But GP practices, others, and say, well, it's nothing to do with me, but how how do people know how to access this? There's no coordination even on what is currently available, and indeed confusion about what my bus, for instance, does, because I've tried this, I've debated this, I have phoned up, we have, did a straw poll of GP practices in the Inverclyde area some time ago, and we were getting different answers, and nothing to do with me, that's up to them. So there is an issue here about the here and now, about whether people know what is available. So they've got a range of options to be able to visit someone in the hospital, or even wider, or to fulfil an appointment at the hospital or the GP practice. And there seems to be an absence there. Is that a general thing, or is it just me and getting a bee in my bonnet about all of this? Anne?
I mean, within NHS Greater Glasgow and Clyde, the information that patients get when they are being admitted to hospital or coming for an outpatient appointment should include information about transport options. It should include information about the eligibility for an ambulance, and it should include information about the travel line that Heather mentioned in terms of planning your journey. And certainly we make that information available in our patient information centres. So rather than publish a timetable, what it would be is about a journey from destination A to destination B, because as Heather said, sometimes it might be 2 buses, or it might be a bus and a train, or a bus and a ferry in the case of Inverclyde. So we would use travel line to provide that information. I can't speak to GP surgeries, but I can certainly pick that up with the CHP director.
It doesn't happen when someone is told, because to take their child to IRH in Paisley to the children's ward, The GP said, no, take them to the children's ward. And on that day, I think it was the WRVS, through some connection with a social worker, whatever, were down the line, and a relationship and a network that was working, that came and picked that grandmother, actually, and that child, and took it to Paisley. So on those occasions, you know, it's, if they had a car, they would go in the car, but not everybody's got the car. Peter.
I mean, I think all of this points to two things. One is about better relationships at a local level and linking up what services are available and linking that up with the technology. And the second thing is about structures. And I think it's very welcome that you're looking at this in the context of health and social care integration, in the context of reshaping care for older people. Because I think those structures are the sorts of things that will allow us to create services that meet the sorts of needs the convener's talking about much better. And I think for some time, and perhaps it's slightly unfair to say this, but community transport's been a little bit of a Cinderella service. It's been something that comes at the end of the list of services that health boards or local authorities think about providing, and raising the profile of that and getting better relationships and getting better thinking about it are the sorts of things that I think will lead us to getting better outcomes, because knowing who the right people are and having the right structures in place is what will deliver that.
Any other members? No. Can I thank you all for the time that you've given us this morning and the evidence provided. Thank you all very much. We're going to suspend at this point and go into private session.
We're still public for the annual report.
Oh, is it? Still, no, we're not. Still public for the annual report. We now move to agenda item number 4, which is consideration of a draft annual report. And you know, it follows a standard format here in terms of length, etc., set out by the conveners group. Are members content with the draft report, annual report?
Yes.
Okay, thank you all very much. I thank all of those who contributed to bringing that annual report together. All the hard work was duly recognised there, if you hadn't noticed. We now go into private session. And